To all, at the outset, I'd like to take this opportunity to thank Dr. Curator'S and also late Dr. Borges, who was my mentor, for giving me this opportunity. And I'm very happy to be presenting today with Dr. Divya Meeda, who's a wonderful colleague and a great teacher, as you will see ahead. So without further ado, I'll just start my topic. I'll give a little intro on endometrial tumors, and then we will start with the cases. So endometrial carcinoma is one of the most common gynecological malignancies in the developed countries and the most prevalent cancer in women. Sixth most common cause of cancer mortality in women, and most cases arise in the postmenopausal period with a mean age of 60 years. Now, how are these tumors detected? Just a minute. So the presenting symptoms are usually bleeding, which is menorrhagia, menometrorrhagia, postmenopausal bleeding, watery vaginal discharge, unexplained weight loss, anemia, difficulty urinating, abdominal pain, and abdominal pap smear, which is then translated into a biopsy. Now, what is the approach to management? First is to identify the cause. They usually USG or pelvic or transvaginal ultrasound or a colposcopic examination and an endometrial biopsy are done. So what are the types of endometrial biopsies? Would one of the students like to answer? Neil, would you like to just attempt? What are the types of endometrial biopsies you know?
Endometrial biopsies can be curetage samples can be from DNC and
so DNC is the same as curettage, dilatation and curettage.
Yes.
Right? Any
Curetage
other?
is
Correct.
then it can be part of radical resection also, which we can sample in the.
So that will be the radical resection specimens. So in endometrial biopsies, there are about 3-4 types. So one is the Pipel biopsy. Here, the cervix doesn't need dilatation. Here, a small tube is passed right up to the fundus and you can get material. The disadvantage of this biopsy is you don't get very much material. It's very little material compared to what you just described, dilatation and curettage. So here, the patient unfortunately has to undergo some form of anesthesia to get the cervical dilatation done, but the material you get is definitely much better. So as you can see down, you can see the image of an endometrial curettage. Then there's a hysteroscopic guided biopsy where you can visualize what you're seeing in the uterus, and the gynecologist can identify if there's a polyp or any other pathology and take biopsy from that area. Then there's something called a transcervical resection. Have any of you seen these kind of specimens? Sanjana, have you seen transcervical resection specimens? So here the surgeon views and performs the procedure through a hysteroscope. So here, in this procedure, there is not only the endometrium removed, but a part of the underlying myometrium. So this procedure is reserved for very specific circumstances. It is not done like in usual circumstances. So these are selection criteria for a PCRE. Patient has abnormal or excessive bleeding, but it has to justify a hysterectomy. No relief from medical therapy, and the patient should have completed her family. And why is all these criteria needed for a TCRE? It's because when you remove not only the endometrial lining, the basal layer, but the underlying myometrium, post this procedure, you can have chances of fibrosis in the uterus. And some patients don't conceive. So this is a procedure which is done as a last resort. Unless you're planning a hysterectomy, you don't go ahead for this kind of a biopsy. So pathophysiology of endometrial tumors. Endometrial carcinomas have been traditionally divided into 2 groups. Type 1, often seen in younger women. They're non-aggressive, low-grade histology, the endometrioid or mucinous. And type 2, which are seen in older women postmenopausal, which are estrogen independent and high grade. And these are usually grade 3 endometrioid adenocarcinomas, clear cell, serous, undifferentiated, carcinosarcomas, mixed carcinomas, and other less common subtypes. So we will go through these subtypes in this presentation, but this is just the overview. So what is the reason for these high levels of circulating estrogen in these estrogen responsive tumors? So in premenopausal women, it is often due to polycystic ovarian syndrome or chronic anovulation. In peri and postmenopausal women, it could be due to exogenous estrogen, which is given for some hormone replacement therapy. And at any age, it could be obesity or ovarian pathologies like stromal hyperplasia, hypertrichosis, or hormone-secreting stromal tumors. So these could be the causes of high levels of circulating estrogen in the body, which causes endometrial hyperplasia and then neoplasia. Now, what will a gynecologist or a surgeon want from an endometrial carcinoma report? Sanjana, you'd like to tell me what they would like? Sanjana, are you there? Okay, so it depends on the type of sample received. If endometrial biopsy or curating, then what they're looking for is a diagnosis, the type of carcinoma, the grade of carcinoma. But if it's a resection specimen, a hysterectomy, then they are looking for the staging because they already have the diagnosis of carcinoma, the type and grade, so they're looking for the staging. But what are the implications of a biopsy report and why it is important what we report in a biopsy? Patients with low-grade endometrioid carcinoma may be eligible for the least radical extent of surgery and lymph node sampling, or if desired, may be eligible for fertility-sparing management. And patients with high-grade endometrial carcinoma generally require much more extensive surgery, and they're not eligible for fertility-sparing management. We'll go more into detail in this a little later. Now we'll start with case one. Neil, would you like to take case one?
Yes, ma'am.
Okay. So you'd like to read the history or should I read it for you?
I'll read, ma'am.
Sure. Thank you. Go ahead, Neil.
58-year-old female presented with abdominal pain. Ultrasound showed a right ovarian mass measuring 8 into 8 into 6 centimeters. Endometrium was mildly thickened. Laparoscopic right salpingo-oophorectomy was done outside for ovarian mass, was diagnosed as a carcinoma. Subsequently, patient was planned for hysterectomy with left salpingo-oophorectomy, bilateral pelvic para-aortic lymph node dissection, and omentectomy. A section from the hysterectomy is provided.
So to the students, I had provided the path presenter link where they could see the images. Now I've clicked certain images, so a full view of the slide. Any comments on this, Neil?
Yes, ma'am. Section shows endomyometrium with portions of an infiltrating neoplasm. And on low power, we can appreciate the architecture, which is predominantly the epithelium is arranged in a composed of very tightly fused glands with little intervening spaces. And apart from that, there are some solid pink areas as well on higher magnification, which revealed to be kind of squamous areas. And talking about the neoplastic component, these were the endometrial glands, which exhibited mild degree of pleomorphism with oval to elongated nuclei and a kind of vesicular chromatin with prominent nucleoli. And mitosis was frequent, it wasn't that high now. And apart from this areas of squamous morules were noted adjacent to the neoplasm. And
Okay, good.
invasion into myometrium was also seen in one of the images. And the stroma around it showed the plastic response as well.
Okay, very good, Neil. Very good. So what would be your diagnosis on histology?
Based on the histomorphology findings, ma'am, I would think this is endometrioid carcinoma, FIGO grade 1.
Fantastic. Very good, Neil. So exactly how Neil has explained, you can see these glands, there's fusion, cryptid forming. In this section, you can see on the left, there is necrosis. And here you can see areas of necrosis, and a little down, you can see the squamous metaplasia. Here on the top of the screen, you can see squamous metaplasia, and you can see these pink ball-like structures between the glands in the lower part. That is actually modular metaplasia. And here, as he has said, there is myometrial invasion. So on diagnosis on histology is, like he said, well-differentiated endometrioid adenocarcinoma, FIGO grade 1, invading more than half the myometrium. So what is the meaning of endometrioid? It means it resembles the endometrial cells of glands. Very good, excellent. And it resembles the endometrial cells or glands in the proliferative phase. So what is EIN and how do you differentiate it from endometrial hyperplasia without atypia? So this is a picture of endometrial hyperplasia without atypia. It is basically an increased gland to stroma ratio, which is more than 3:1. There may be variation in gland size. The glands are uniform and all the glands are the same. There are no different type of glands. But when it comes to endometrial hyperplasia with atypia, which is also known as endometrioid intraepithelial neoplasia, you can see the change in the cytology of the glands. The increased number is still there, crowding, but you can see the normal endometrial glands, which are small, between the very pink, large glands, which have enlarged nuclei in more cytoplasm. And there you can see the distinct morphology from the normal endometrial glands. So this is endometrioid intraepithelial neoplasia. And for a well-differentiated endometrioid adenocarcinoma, there's confluent or back-to-back glands lacking intervening stroma, and there is muscle invasion, which is one of the very important features to say it is definitely an adenocarcinoma. Now, is there any IHC you'd like to do to confirm the histologic diagnosis, Neil?
We can do ERPR and along with that, um,
Very good. ERPR definitely. And there's one marker we do in all endometrial carcinomas, and that is P53. Very good.
P53.
Okay, good. Who is answering there? Because I don't know who is who is online and who can.
Ma'am, can you hear me? I'm Anuradhi. There is an audio
Anuradhi.
problem. Yes, ma'am.
Okay, good. I can hear you clearly, Anuradhi. So you can then take the
There is,
next
I
case because
think, some internet connection problem.
no problem, no
Hello?
problem. So as you can see,
Can you hear me, ma'am?
I can hear you, Anuradhi. So in this case, as you can see, the P53 is a wild type expression. When we say wild type, you can see few weakly staining cells with occasional dark staining cells, but it is not diffusely strong or diffusely absent. So this is a wild type P53 staining. And you can see the ER and PR are strong positive in this tumor because this is a hormone responsive tumor. Okay, where endometrioid adenocarcinoma is well differentiated and hormone responsive. So these are morphologic variations. Here on the left side, you can see the squamous morules, the intragranular ball-like collections of cells which resemble sort of the squamous cells, but they are not actually got a full squamous differentiation. And on the right side, can you see the full squamous differentiation? So,
Yes, ma'am.
Neil,
Yes.
can you give the difference between the two?
Squamous modules are more primitive. They won't have keratinization or intercellular bridging, whereas full formed squamous differentiation will exhibit those
Very
as
good.
well.
So excellent. So this is very important to identify these two changes because they should not be confused with solid areas when you're trying to grade an endometrioid adenocarcinoma. But it is useful when you want to identify in poorly differentiated carcinomas that these are endometrioid because most of the other endometrial tumors do not show squamous differentiation or morular metaplasia. Also in these modules, CD10 comes positive and beta catenin comes a nuclear expression. So if you can see in that picture of beta catenin on the right, you can see the modules have got nuclear positivity and the glands have got membrane positivity. So beta catenin comes nuclear positivity in the modules. It's just a small identification marker to say it is modular metaplasia. Then you can also have other metaplasias. There's mucinous metaplasia and tubular ciliated metaplasia. If you see on the right side of the screen, you can see the cilia at the edges of the glands. So these are also due to increased estrogen in the body, which is estrogen manifestation and metaplasia. So grading of endometrioid adenocarcinomas by the FIGO grading are primarily based on architecture. 5% or less solid growth pattern is grade 1, 6 to 50% non-squamous solid growth pattern is grade 2, and more than 50% is grade 3. Nuclear atypia exceeding that expected for the architectural grade increases the FIGO grade by 1. So the non-aggressive histologic type, which is there, is grade 1 and 2 endometrioid adenocarcinomas. Grade 3 is the aggressive histologic type. So Anuradhi, would you like to tell me what grade you'd like to give this tumor? This is an endometrioid adenocarcinoma based on what we just discussed. Or Neil, you can give your opinion because her connection might be an issue.
I think there are more solid areas as compared to the first slide. So I would increase the grading.
To what grade?
I think it's still less than 50%, so I will stick with grade 2.
Very good. So this is like a grade 2 tumor. There is some tree forming some little appearance of solid area. So it doesn't fit into grade 1. Yes, that will be grade 2. And this here is another example of grade 2, where you can see the more solid areas, but you need to identify what are the percentage of the solid areas. I think somebody has put a question. Do you need to give a grade on biopsy? Yes, if you could, you should give a grade, because on biopsy, if you can see a well-differentiated, you have to say that you are seeing a well-differentiated tumor on the biopsy. You may change in the resection, but at least the clinicians have some sort of guidance. Okay. Now, Neil, would you like to grade this tumor?
Yes, when the solid component is definitely predominant here, so this would be grade 3.
Yes, this looks like a grade 3. There are hardly any glandular formations. You can see some glands, but this is definitely a grade 3. Again, a higher power view of the same. So they are usually solid, but at least focally you see some glands, and the nuclei are usually grade 2 nuclei. Squamous differentiation of morules are a helpful clue. Now, the IHC is also helpful in these grade 3 tumors because P53 still remains wild type, and ER and PR are nice, strong, positive. Now, what is the role of MSI? Do any of you know the role of MSI in endometrial tumors, endometrioid adenocarcinomas? Neil, would you like to try?
Yes, NMR proteins are there, and we check for whether it's proficient or deficient.
Perfect. So these are the 4 MMR proteins: MLH1, PMS2, MSH2, and MSH6. So endometrioid adenocarcinomas, a significant percent can show a loss of MSI or MMR protein deficiency. And it's a universal screening for all endometrial carcinomas for Lynch syndrome. In fact, sometimes it is the presenting symptom in female patients. And not colonic, but endometrial carcinomas are the presenting symptom of Lynch syndrome. So loss of any of the components, especially MSH2 and MSH6, is likely Lynch. If the patient has MLH1 and PMS2 loss, you have to first rule out hypermethylation of MLH1 before you call it a Lynch. It's useful in high-grade endometrial carcinomas with overlapping features because most of the other endometrial carcinomas are not MMR protein deficient, though a subset does show, which we will see later. So these are the molecular subtypes of endometrial carcinomas. Now the whole shifting of endometrial tumors is towards the molecular subtype, as we know with the FIGO 2023 staging. So these are the 4 subtypes. One is the pole mutant, which has the best prognosis, then the MMR deficient, the P53 abnormal, and the no specific molecular subtype. So the importance of pole mutant subtype is that if this patient, even though if they have a grade 3 endometrioid adenocarcinoma, which is otherwise considered an aggressive histology, if they are pole mutant, their treatment is de-escalated. They still come into the 1A group, which is the molecular group. And here, again, if you have a P53 abnormal tumor, the prognosis is the worst of all these, and patient requires much more treatment. So this is just a short table giving an overview summary of the subtypes and their implications. Carcinoma stage is the strongest predictor of outcome. As we know, there are 2 main staging systems, but the revised 2023 staging takes the histologic types as well as the molecular features into account. So here the staging has changed a bit from tumors confined to uterine corpus and ovary with invasion of cervical stroma, extrauterine extension, and with substantial LVSI or aggressive histologic types. So I'll go into that a little more. So staging is now dependent on non-aggressive or aggressive histology, the depth of invasion, cervical stromal invasion, lymphovascular space invasion, and the rest of the criteria which were followed earlier, as well as the molecular sub. Now, if you can see the lymphovascular emboli, they can be focal or substantial. So substantial is when it is more than 5 vessels involved, and that is in the WHO 2021. It's given that more than 5 vessels involved. So as you can see here in these case images down, that is a substantial LVSI. So these have a little worse prognosis, and they are given a higher stage, even if they are well-differentiated tumors. So there's also this MELF pattern of invasion, a picture which I put here, which is just a pattern of invasion in endometrioid adenocarcinomas, which has a higher propensity of lymph nodal metastasis. But there is no change effect of this on the grading in the FIGO staging. But it's just a new thing which comes up as it's a microcystic, elongated, and fragmented pattern of invasion. And this histiocytoid morphology, which you can see here, the pink cells, they sometimes are so subtle that you might actually miss seeing them. So that's why they've described this pattern, microcystic, elongated, and fragmented pattern of invasion in endometrioid adenocarcinomas. Now, carcinoma involving adenomyosis is not considered invasion. So you have to be very careful when you see carcinoma involving adenomyotic foci. In the bottom left image, you can see the carcinoma, 2 glands with the benign endometrial glands at the periphery and the stroma. And if you want to assess myometrial invasion in areas arising from adenomyosis, you have to identify the deepest myoinvasive point, and that would be considered the depth of invasion. So invasion of cervical stroma is also now you have to try to divide it between less than 33%, less than 66, or more than 66%. The estimation of depth of cervical wall invasion may be used to determine the adjuvant radiation. So that's why it's important to give it in your report as far as possible. What is the depth of invasion of the cervical stroma? So as we know, the 2023 FIGO staging also includes the molecular subtype. So like I told you earlier, for tumors pole mutant confined to the uterine corpus or with cervical extension, regardless of the degree of LVSI or the histologic type. So even if it's an aggressive histologic type, it is still classified as a stage 1A tumor, because once they're pole mutant, they behave much better than the other usual histological aggressive types. Then the stage 2C is for any P53 abnormal endometrial carcinoma, even if it's confined to the endometrium or confined to the uterine corpus without any myometrial invasion, with or without cervical invasion, regardless of LVSI or histologic type. So now we go to case 2. Anuradhi, would you like to take it on? Is your connection okay?
Excuse me, ma'am, we have some questions.
Yeah, sure. Should I take the questions at the end, or should I?
Actually, ma'am, I think they are related to the cases.
Okay, please go ahead. Okay. I'm sorry, I can't see the questions here. Okay, if you can read them, Bushra, I'll answer them.
Yes, ma'am. Ma'am, an attendee has asked that please explain the difference between disordered proliferative endometrium and endometrial hyperplasia.
So disordered proliferative endometrium again is increased in the gland to stroma ratio, but it is usually not that much, and more than 3:1. And you can see the glands are dilated in various shapes and sizes. Now, honestly speaking, in young proliferating, in young women with proliferating endometria, it doesn't usually make a difference when you call it disordered proliferative or endometrial hyperplasia. But it makes a difference in elderly women because these might be postmenopausal. You don't expect to see hyperplasia of the endometrium, perimenopausal, postmenopausal. So there, if you're getting a hyperplastic or disordered kind of proliferation in that age group, then it is more likely to be hyperplasia than the disordered proliferative. So it is all a spectrum of changes, and it doesn't really matter too much whether you want to call it disordered proliferative or you call it hyperplasia. Important is to rule out that there is no atypia. Okay, Bushra, can I have the next question?
Ma'am, someone is asking what is MELF?
That's microcystic elongated and fragmented pattern of invasion. It's a type of invasion which I described in endometrioid adenocarcinomas, and it has propensity for increased lymph node metastasis and lymphovascular invasion. So it just has to be noted if it is seen on the histology, but it's a very subtle change, the histiocytoid change. So you have to look for it. Along with the histiocytoid change, there is a dense acute inflammatory infiltrate as well as a stromal reaction, which was seen in that slide. Okay. How is atypia differentiated from tangential cut section of, sorry, I didn't get the full question. Musha, can you just tell that, read that question?
Yes, ma'am.
Yeah, okay.
How is atypia differentiated from tangential cut from actual nuclear atypia?
Okay. Hyperplasia different from actual nuclear atypia. So if you're having an issue in your section, which is having, you are not able to identify, then it would be best to do a serial deep cut, because if there's anything which is tangential and looks odd, that gets cleared up in our serial deep sections. Because if it is hyperplasia with atypia, it will not change. All the glands will have the similar changes. But if it is just a tangential cut, then that abnormality, which is focal, will disappear.
Okay, ma'am. There's another question. How to differentiate P53 mutated high-grade endometrioid carcinoma from high-grade serous, which is already P53 mutated? Is the prognosis same?
Correct. So can we, you know what, I'll answer that after this next one, next 2-3 cases, because after you get a little overview, then you'll understand these questions might get answered in that. So I will take that question a little later. Okay, so we'll go to the next case. This is a 29-year-old lady with menorrhagia since 2 months, bleeding not subsiding with hormonal medication. The ultrasound thickened endometrium polyp, decision taken for endometrial biopsy. Who would like to take this case? Is anyone volunteering? Because Anil has already finished.
Good evening, ma'am.
Good evening. Nangsan, yes, great.
Yes, ma'am. I would like to attempt this case, ma'am.
Please, can you describe what you're seeing in short?
Ma'am, section study shows multiple fragments of endometrial tissues arranged in polypoidal architecture. The fragments contained variably sized and irregularly shaped endometrial glands embedded in a fibrous stroma. Several glands are cystically dilated and showing complex branching and back-to-back and crowding arrangement. The glands are lined by what seems to be like a proliferative type of columnar epithelium with some kind of with atypia, and intervening stroma is also present. No definite stromal invasion is seen, and the glands, coming back to the glands, it looks very back-to-back, some kind of malignancy is there, and individual cells are round to oval, and nuclear pleomorphism are also seen in the case, ma'am. And fibrovascular stromal pores and focal glandular crowding is also seen. And the differential diagnosis, first, the most common possibility is endometrial polyp with and disordered proliferative endometrium, and endometrial hyperplasia without atypia, or atypical endometrial hyperplasia, pre-malignant lesion because of the back-to-back crowded arrangement.
Okay. Do all the other students agree with this diagnosis? Neil, would you like to?
Like one of the fragments was particularly polypoidal, and like he rightly said, there are some cystically dilated glands. But the glands I found mainly it was very bland, and the stroma surrounding it was kind of hypercellular, and stroma was the atypical thing, I would rather say, and at some places it's quite packed also around those glands. And some areas of squamous differentiation was also there in one of the images.
Correct.
And so what I thought was it could be adenosarcoma or polypoidal adenomyomatous. Just forgetting the name.
Polyp.
Yeah.
Okay, so let me just explain. So these are the multiple bits we saw, okay, on low power. Now, if you can see, there's a polypoid bit with some dilated glands in the center, and at the periphery, you can see very crowded glands. Okay, so now we'll just go to higher power view of the center one. You can see these glands which are here. If you see the glands, they're very banal looking. They're looking benign.
Very
They're not
bland.
looking anything. Correct, very, very benign. You can see thick walled blood vessels in the stroma. And so this is probably some polyp. And in the stromal cells, we can see they're very pink. Can you see the stromal cells? They're all pink in the background. This is like the stroma is undergoing, like, pre-residualization. It's the late secretory kind of stroma. And the glands and this at least are looking benign. But if you go to this area, they're definitely looking quite bad. There's nuclear atypia, there's crowding, there's fusion of the glands. This, if you had got, now this, did you notice the history in this? She was a 29-year-old girl.
Yes, ma'am.
Yes. So now, if you had got this in a 50-year-old, you would have said, oh, this is like probably an EIN versus a well-differentiated adenocarcinoma. There's a small focus of squamous differentiation. Here, there is nice modular metaplasia, squamous metaplasia, what we saw in the other case itself. So there's squamous differentiation, modular metaplasia. Again, these glands see and a few atypical, low-grade atypia, but it would fit into EIN or a well-differentiated. Here in this, you can see again the benign looking glands, which are in that stroma, which is sort of like a progesterone effect. And here there are bits of myometrium. Can you see the thick pink bands of myometrium?
Yes,
On the left is the endometrium, and then there's myometrium. As we go into higher power, you can see the left, the endometrial glands, and in the myometrium, can you see the glands in the myometrium?
yes.
Okay, on the right side. Now I'm going higher power. Now these glands are in the myometrium. They are not looking benign. They have atypia. So now these are looking, the same glands which are looking bad are also invading the myometrium. So what do you make of this then?
Uh,
Anyone
ma'am,
would like to?
ma'am,
Yeah, tell me.
are you hearing me? My voice?
Yes, I can hear you. I can hear you.
Ma'am, can be it endometrioid adenocarcinoma with squamous differentiation?
Yes, very good. This is exactly like that because it's like the other case. You're seeing squamous modules, you're seeing well-differentiated glands having atypia, but these glands are not limited to the endometrium. They are now going into the myometrium. So if you're having, what are the criteria we said for a well-differentiated endometrioid adenocarcinoma? It is muscle invasion is one of the main criteria, and this is not the muscle of a polyp. This is myometrial tissue. So now it comes in a 29-year-old. Do you want to call this a well-differentiated endometrioid adenocarcinoma? And what are the implications when you give this report on a biopsy? So there is no doubt. Yes, tell me.
In this focus, the glands per se, I think, like to me, it occurred as like it's crushed kind of because it's kind of wavy. So I didn't thought these to be like malignant glands.
Okay.
Exactly,
No,
ma'am. Ma'am, in this focus, which you have shown, ma'am, some like they're small and they're irregular, ma'am. So there was I had a confusion whether it will be a malignant or maybe because of the sectioning of the tissue. So
understood. So when you have glands which are going into myometrium, when do you see them on a histology section? You see it when you have adenomyosis, right? So in adenomyosis, there is a stroma associated with it. But in these, you can see the glands having some atypia, which are going. There's even a focus at the bottom, which is showing cribriforming.
Yes,
so all the glands seem to be fused, right?
Yes.
So there is no stroma around these glands. And if you see in any well-differentiated, if you saw the previous case, there is also the glands going to into the muscle. There's not always a prominent stromal reaction, but yes, you can see the glands going into the myometrium without any stroma surrounding them. If it is stroma surrounding, then it's adenomyosis. But in this, there is not. So these are actually atypical glands going into the myometrium.
So
here
there's
you can
invasion of the glands into the
myometrium, correct. So this in an elderly patient, without hesitation, I would have called this and features of a well-differentiated endometrioid adenocarcinoma, FIGO grade 1, with in the curatings, this has come as myometrial invasion also. But now this is 29-year-old. So what can be done for her? So can fertility be preserved? Because this is a 29-year-old. If lesions are confined to the endometrium, which is even a FIGO grade 1 endometrioid adenocarcinoma or superficial myometrium, patients who desire pregnancy, they can conserve the uterus, but it requires very strict surveillance. So I had given this report as an atypical endometrial proliferation, histologically indistinguishable from a well-differentiated endometrioid adenocarcinoma. And atypical endometrial proliferations in young women often respond to hormonal manipulation. Now, when I say this line, This proliferation, however, shows myometrial invasion. It is also noted that the patient has been on hormonal treatment recently. So if you see that those glands which had the benign looking glands with the stroma, which was pink, which I showed you, which is like a pre-decetalized stroma, that is progesterone effect in the endometrium. So you could see it even on the slide without being told, because then I asked for the history, and that is what I came to know, that this patient has been having hormonal treatment for last 2 months because of the bleeding. So you can see the changes on the endometrium, yet the entire endometrium has not responded. So a critical review of the radiology in view of the current findings is recommended for appropriate clinical management. In addition to this, there are strict criteria, which are recommendations by the ESCO-ESP guidelines, which is the European Society of Gynec-Oncology, Radiation Oncology and Pathology. So for these patients who want to preserve fertility, they have to do a strict follow-up. They have to be investigated for genetic risk factors, preferably without myometrial invasion is preferred, but even superficial myometrial invasion, they do allow it under strict follow-up. They have to be given intrauterine progestin therapy with levonorgestrel releasing agents, and they have to be on a 3 to 4 or 6 monthly follow-up with ultrasound, and they have to be fully aware that at any point they can be converted for a hysterectomy. And after the child, the patient has had, say, one or more children, they have to undergo a hysterectomy because they have a tendency to develop these tumors. Okay. So now we go to the next case. It's a 65-year-old postmenopausal bleeding endometrial curettage done. Who would like to take this case?
Hello. Hello.
Hello, yes. Yes, tell me.
Ma'am, can you
Who's
hear?
that?
Anrati. Anrati.
Yeah, tell me, Rati.
Ma'am, this is a case 65-year-old female postmenopausal bleeding endometrial curettage done. This is a postmenopausal woman, मतलब older woman, and here it is a atropic endometrium. There is a multiple detached papillary fragment, and there is a in a high power we can see a eosinophilic some eosinophilic cytoplasm, and some tumor cells in the lumen of papilla. There is some mitotic figure also, ma'am. I can see.
Very good, Rati.
I am suspecting this is a serous adenocarcinoma.
Okay, very good. I've just flash the images because you are describing it. You don't know which is the order. So like you described, there are papillary areas, there are solid areas,
Ma'am,
there
there
are
is a multiple detached papillary fragment in low power also.
Low power, you can see the multiple detached papillary fragments.
Yes, ma'am.
And here you can see this is a polyp which is having the atrophic cystically dilated endometrium, which you have just described. And at the edge of the polyp, the lower edge, you can see this proliferation of glands which look different from those benign glands, which are seen. Okay, but here you can see the nuclear atypia, you can see the higher grade nuclei, and you can see the lining of the polyp on the right, which is also showing nuclear atypia.
Yes, ma'am.
Again, a very crowded slide with the glands all back to back, and they look higher grade. Some in sheets and abundant papillae. On the right, you can see it's the polypoid fragment with the glands with high nuclear grade there. So what Rati you described is correct.
Okay.
And on histology, with this morphology, eosinophilic cytoplasm, large high-grade nuclei, and there are quite a few mitoses, even some atypical mitosis. Correct.
Yes,
This is a high-grade carcinoma. It has a serous morphology, and that is of no doubt. So this is a serous carcinoma of the endometrium. What is the IHC you would like to do in this? Okay, before we go into the IHC, these are the morphologies. I just clicked some random pictures, papillary, solid, and glandular. The cytoplasm can be scanned, but you can have eosinophilic or clear cytoplasm, the high-grade nuclei, and pleomorphic bizarre forms with numerous mitotic figures. Okay, what is the IHC profile you'd like to do for this?
Ma'am, as you said earlier, P53, in this case, serous case, there is a mutant pattern, while in endometrioid, there is a wild pattern. And we can go also for the P16, which is in case of a serous, it is a diffuse type, matlab overall covering whole area.
Okay. Very good, Rati, very good. So this is the P53 mutant expression, diffuse strong nuclear staining. And this is the P16, which you described, also diffuse and strong.
And
Now, yeah,
ma'am,
tell me.
ER and PR in this case negative. In
Yes.
endometrioid it is positive, but in serous it is negative.
Yes. So there can be negative, it can be weakly positive. Some cases are also a little more strongly positive, but definitely less than the endometrioid. Now, I wanted to, so I'll show you this is the P53 mutant, which you saw is overexpression, and this is P53 loss, which is also a mutant expression in a high-grade serous carcinoma. And when you're seeing a P53 loss, you always have to look at the internal control. So if you can see maybe on the right image, which is the little higher power view, I'm sorry, my pointer is given a bit of an issue, so I'm not able to point, but you can see the cores of blood vessels, which are having small dots, which are dark, which is the
Yes.
internal control, which is showing that the test has worked, but the tumor cells are mutant. They're mutant means they're lost. The nuclear expression is completely lost. It is no wild type expression. Okay, in the cell. Yeah, so this is a mutant expression, which is a loss, P53 loss. In addition, you can have a third type of mutant expression. I don't have that case with me, but that is the cytoplasmic expression of P53. It is not nuclear, it is not completely lost, but it's completely cytoplasmic. So there are three types of mutant expressions of P53. One is overexpression, strong diffuse. Second is loss, and third is a cytoplasmic expression. Okay. And this is now ER and PR, like you said, it's usually weak or lost or negative in some cases. But important of a serous carcinoma is that it develops in the background of atrophic endometrium. So this is, yeah, so you can see all atrophic endometrium, but it can arise on the surface of an endometrial polyp. So if you see in the lower image, you can see the whole polyp, and you can see on the surface, these cells look very crowded. On a higher power view, you can see they're crowded, they're enlarged nuclei, they look different from the other glands. And if you do a P53, then you see the mutant expression in that, in the surface of that polyp. Now, why it's important to diagnose this even the surface of a polyp? There's no invasion. It is only in the surface of a polyp. So another area is here where you can see the normal, glands, and you can see these glands. Now, these are not invasive glands. They're preformed glands of the polyp, but they're seeing very, atypical looking nuclei. And if you do the P53, then this is mutant. So importance of serous carcinoma and EIC. Earlier it was called as intraepithelial carcinoma, but this terminology is now discouraged because even if they occur on the surface of the polyp, or within the preformed glands, they can present with metastasis, like a high stage outside the uterus. So they are no longer classified like an in situ carcinoma as it is thought of in EIN. Now, EIN, when you say endometrioid intraepithelial neoplasia, it is like they do not metastasize, they're just limited to the endometrium. But the same when you convert it for a serous tumor, that's an aggressive histologic type, they do not behave like an in situ carcinoma. So these are no longer classified like in situ carcinomas. You have to call them serous carcinomas even if they are confined to the surface of a polyp or in preformed endometrial glands. So other IHC is WT1 is negative in majority, but some of them do show WT1 positivity. Role of MSI, they're usually not MSI high, and HER2 can be overexpressed in more than 30% of tumors. And in patients with recurrent or advanced disease, they can be treated with trastuzumab or deruxtecan combination, which is added to the usual regimen of carboplatin and paclitaxel. So it's many times now requests have come for HER2 because it is part of the management. So there are guidelines for reporting HER2 in serous carcinomas, which are P53 mutant. And I just give you one example. This is the same case which you saw today, this case number 3. So this is HER2 score 2. So a cluster of 5 or more cells in a biopsy specimen, which is having weak to moderate complete basolateral or staining, is considered HER2 score 2 plus. And here is a score 3 plus, where you can see complete membrane staining in the more than 5 tumor cells. But this is, and then if it is a resection specimen, you have to see it in more than 10%. So if this was a resection, even there, it would be quite a significant percentage. So it would definitely be a HER2 score 3 plus. So points to note in endometrial serous carcinoma, it's seen in the background of atrophic endometrium, can arise on the surface of an endometrial polyp, P53 is mutant, P16 is diffusely present. These on molecular level, they have P53 mutations, and the treatment is primarily surgical and platinum-based chemotherapy and radiotherapy, and trastuzumab deruxtecan if HER2 is positive. Now, I think there was a query of how to differentiate endometrioid P53 mutant and serous mutant P53. I agree, it is sometimes a very difficult task. Like P16 would help. P16 comes usually in the high-grade serous. The second is ER and PR, which comes nice and strong or stronger in the endometrioid and less in the serous carcinomas. HER2 is another thing which comes usually in serous carcinomas, and MSI. MSI is a very good marker to differentiate because most of the serous are never MSI high. The other thing is that if you have on histology anywhere squamous modules, squamous metaplasia, mucinous metaplasia, it's more likely to be an endometrioid carcinoma because these are estrogen responsive tumors, and due to increased estrogen, they can have all these metaplasias. Well, that is not the case with the serous tumor. So so these are all things. If all these criteria you try with histology, with IHC, and you're still not able to identify whether it's endometrioid or it is serous, you can still give it as a high-grade P53 mutant endometrial adenocarcinoma, and then they can now all endometrial tumors, almost all, are going for molecular workup because the risk stratification and the management is now dependent on the molecular profile, which we will also discuss later, and Dr. Divya Mida will cover it in more detail. So we will go to the next case. This is a 72-year-old lady with postmenopausal bleeding, hysterectomy done. Who would like to take this case? Are there any takers for this? Any one of you who has already done can also take it on. Neil, would you like to try it?
Dr. Sanjana, Dr. Angasan, would you like to take this case? Neil, would you like to take this case?
Okay, it doesn't matter if they do not want. I'll just explain what we're seeing. So this is 72-year-old. Here the history, postmenopausal hysterectomy done. We're seeing a tumor which is exophytic and as well as going. The myometrium seems to have. Oh, Neil is muted. Sorry, Neil has put a.
Yeah, please unmute Neil.
Yeah, sorry, Tanya. I have been having little difficulty with the pointer. I use it, but if I hope I can try to describe the areas with the area, but I'm not able to use the pointer in this presentation. Anyway, Neil, you can go ahead.
Second shows endometrium with portions of an infiltrating neoplasm comprising neoplastic endometrial epithelium arranged predominantly in a closely packed nests and microcystic spaces. The individual neoplastic cells are kind of oval in shape with prominent cell borders with exhibiting a moderate degree of nuclear pleomorphism with oval nuclei, irregular nuclear membranes with kind of vesicular chromatin and prominent nuclei. The cytoplasm is characteristically very clear, and also seeing openly of the cells into the lumen. And the intervening stroma is very scant. Based on the and mitosis was brisk, I would say. So based on the above histomorphological features, I was thinking it along the lines of clear cell endometrioid carcinoma.
Okay. Okay, very good, Neil. You've explained it nicely. You gave your diagnosis as a clear cell endometrioid carcinoma, correct? So
Yes.
you want to say it's a clear cell variant of an endometrioid carcinoma? Or you
No,
want to
ma'am.
say
I
a
think
clear
it's
cell
a
carcinoma?
distinct clear cell carcinoma.
Correct. So you should know that there are these two entities. One is a clear cell carcinoma, which this case is. It has a typical morphology, but there's also something called as a clear cell variant of an endometrioid carcinoma, which can have a slightly variant morphology, which has some areas of clear cells, but it also has the typical morphology of an endometrioid. So now, if you can see, like he described, these are tumors, polygonal cells with large cells, abundant clear cytoplasm, some eosinophilic vesicular nuclei. And here you can see they are like tubular pattern with distinct membranes at the periphery. There's a lot of cystic change. Here there's some papillary pattern, which you can see. And solid sheets. There are some cells which the nuclei seem to be coming out or trying to come out. So that's like a hobnail pattern. So this is on histology, a clear cell carcinoma of the endometrium. The architectural patterns you see are either solid, papillary, tubulocystic, and they are, like I described, the polygonal cells. And you can have these nuclei protruding from the surface, which you can see in this picture down, which is like the hobnail, you know, the nail which projects from the surface of the shoe. So this is like a hobnail pattern, which is very typically seen in clear cell carcinoma. In some or other area, you'll find this hobnail pattern. So what is the IHC profile? Neil, would you know what is the IHC for the clear cell carcinoma?
This one, ERPR is generally negative. Absent A, we would do none. It's generally positive.
Very good. So this is
P53
the
can
one.
be variable.
Yeah, P53 is usually a wild type in a clear cell carcinoma, which is not very strong diffuse. Napsinase usually comes strong positive, but though in this image you can see napsinase come nice and strong and it looks diffuse, but if you can see on the left side of the tumor, that part is not stained. So napsinase can be strong, but it can be focal as well. HNF1 beta is another marker, which is like almost comes in 100% of the clear cell carcinomas, and it is strong and diffuse. And Amacar is another marker, racemase or Amacar, which also comes focally positive in clear cell carcinoma. So this is the usual immunoprofile. In addition to this, what is the ERPR in a clear cell carcinoma, Neil? Or
It's
any of
generally
you?
negative.
It's negative. So that is a very important clue also. One is the P53 wild type, ERPR negative, napsinase strong focal or diffuse, and HNF1 beta diffuse. So there are no definite precursor lesions in this. Clear cell carcinomas occur in postmenopausal women. They are often associated with endometrioid adenocarcinomas. That is something you should know. And in with that, they also have sometimes MSI profile, which is of similar to endometrioid, but most of them, about 70%, are no specific molecular profile. But there are a few which you can have P53 mutant, P53 mutant type, as well as MMR protein deficient. If it is P53 abnormal expression pattern, then it has a worse prognosis. Though clear cell carcinoma, doesn't look that bad on histology sometimes. It can be sometimes quite bland looking. You may not see so many mitosis or necrosis, but they are grade 3 tumors. So they are aggressive histologic type. So age and stage are important prognostic factors in a clear cell carcinoma. So this is just an overview of what are the ones we have discussed now: endometrioid, low grade, high grade, serous, and clear cell. And their immunoprofiles, ER and PR are nicely positive in endometrioid, but they're negative or weak in clear cell and serous. P16 is usually strong only in serous. P53 is wild type in most except serous, which has a P53 mutated pattern. And napsin HNF1 beta and racemase come usually in the clear cell carcinoma. So we will go into more detail. Dr. Divya will take additional cases. If there are any questions in this, I can address them. I'm not seeing the chat box. So Bushra, if you could just tell me the questions pertaining to these cases I have not answered, I'll be happy to answer them.
Yes, ma'am. There are some questions. There's a question: will true myometrial invasion by malignant glands show a desmoplastic reaction?
Yeah, so it doesn't always show a clear-cut desmoplastic reaction, because sometimes you can see the gland squeezing through the myometrium. But if it is an adenomyotic proliferation going through the myometrium, it can go quite deep. Like I said, you'll always see a surrounding rim of endometrial stroma, and that's how you identify that it is adenomyosis and not true invasion. Okay, the next
The
question.
question is related to case number 2. Is there a
Yes.
possibility of Lynch syndrome?
Yes, definitely. I mean, there is a possibility. This patient requires a genetic workup first. So that was primarily which will be done for her. And then after that, the prognosis and the thing has to be explained to her that is it possible or not possible, because she has to have this endometrial proliferation, which is so atypical at such a young age, means she has something which is more than just estrogen related. And though we know that, estrogen sensitivity of these tumors is high and they can have really bad proliferations, but many of them revert completely. And we have seen cases that, given appropriate hormonal treatment, they revert to almost normal, they conceive, and then after conceiving, they have had hysterectomies. But this patient in particular had myometrial invasion, which was not very good. So she needed really close follow-up. And she's being currently investigated actually for all the genetic factors. So I don't have that data with me.
There's a question. Can serous endometrial carcinoma present as diffuse, widely spaced, well-formed myoinvasive glands?
Yes, it can. So you have to see the nuclear atypia, the p53 mutant expression, and of course p16 will be added to it. But the morphology of the tumor will be the serous morphology. It's the same. It's a glandular pattern, and you can have well-spaced myoinvasive gland.
Okay, ma'am. These were the questions.
Yeah.
Ma'am, there's another question. In a small biopsy showing adenocarcinoma with high-grade features and IHC is ER positive and PR negative, but HER2 is 3+, should it be reported as serous or high-grade endometrioid?
So they have actually, see, it depends on the morphology of the tumor, like I said. Now, I don't know, the endometrioid tumors, they do resemble the endometrial glands. That's why they're called endometrioid. There is a subset of endometrioid adenocarcinomas which have a low-grade histology and also have a p53 mutant expression that has been described. There's a subset, and even now people struggle where to put these tumors in the FIGO staging, whether they should be classified as the low-grade because they have the low-grade histology, but they have the p53 mutant expression. So there is always there are some cases which do have ambiguity. So if you have something which is looking already high grade, then definitely you can at least give it as a high grade p53 mutant adenocarcinoma. And because of the HER2 positivity, you can favor a serous because they're more common in serous. But like you are asking the question, but I don't know what the histology looks like. When you say high grade, what is the type of histology? Because now we also have various variant patterns, which will be discussed by Dr. Divya Mehta. Okay, I hope that answered your question.
Okay, ma'am. Dr. Ankita is asking about P10 mutation. I think she's asking related to case number 2.
Yeah, so P10 mutations can also be there, but so that is what she has to have a workup before you classify her into whether she's genetically related endometrial carcinoma, or she is just a isolated thing which is estrogen sensitive tumor. So now I think I welcome Dr. Divya Mehta to continue the presentation. I'll just stop sharing. Just 1 second.
Am I audible?
Yeah.
Yes, ma'am.
Yes.
Good evening, everyone. At the outset, my heartfelt gratitude to Borges Madam, who conceptualized this teaching program, which has such a fantastic outreach. I'm sure she's smiling down upon all of us. Thank you, Gujral sir, for your continued efforts and this phenomenal job of keeping this teaching program going. Thank you, Dr. Alina, for being a fabulous teacher, number one, and for being my partner in not one, but more than one of these teaching programs. And I love taking endometrial neoplasms because you lead, in the beginning so well. Thank you, Dr. Nausheen, Dr. Bushra, for moderating this and for taking all the questions so well. And biggest thanks to our online attendees, to Dr. Neil, Sanjana, Chaitra, Nangsan, Manya, Anurathi, and Ishan, and all the other online attendees. I was going through the list. It's so heartwarming to see all of you. attending this. I'm now going to share my screen and let me know if you can see it. You can see my screen?
Yes, ma'am, we can see your screen.
Just give me a minute for me to hide the panel. Just a second. Yeah. And I'm going to try and use the pointer option. You can see the pointer?
Yes, ma'am.
All right. Thank you very much. So how I plan to engage you for the next, I think it's 1 hour, because I would like to do a recap of what you learned quickly. We're going to do 8 cases. I have already sent you the snapshots. There are some polls attached to not all the cases, but I think there are polls with 6 cases. And there will be some concluding remarks. And the polls are in the form of a Slido, which needs you to keep your phones near your side so that you can scan the QR code when it comes, and then you can participate by putting the option in. It's not very complicated. The QR code will come on your screen, and then you can scan it and you can participate in the poll. And I would like to take the Q&A in the end so that the flow is maintained. But in the middle, I will ask some of you to describe the slides. So I hope this works for everyone. Okay. So Dr. Alina so elegantly described how we have moved from a dualistic model of endometrial carcinoma. We were earlier talking about type 1 and type 2 in 1980s. And you know that this is a very subjective way of addressing endometrial carcinomas. And there is a lot of overlap because type 1 is the endometrioid. And she described endometrioid means one resembling the normal proliferative endometrium, whereas a type 2 is a mixture of so many tumors, serous, clear cell, and there are more I'm going to show you. So there was a lot of overlap. And because of the overlap, it led to an overlap in prognosis and an overlap in the treatment. And the patients that's not a very ideal situation. But 30 years later came the molecular classification of endometrial carcinoma, where the overlap kind of disappeared, and the TCGA divided endometrial carcinomas into 4 non-overlapping categories according to the genetic and epigenetic features. You had the ultra-mutated phenotype seen in 4 to 12% cases caused by the DNA polymerase epsilon pol E mutations. You had the hyper-mutated phenotype in, say, around 20 to 40% cases caused by DNA mismatch repair deficiencies leading to microsatellite instability. Then there was a copy number high phenotype in 8 to 25%, which was seen associated with TP53 mutations, where P53 IHC was used as a surrogate marker and associated with very bad prognosis. And if you didn't have all these 3, you were left with copy number low phenotype or the no specific molecular profile, the most common one, which is your 30 to 60% of the cases. So this is a picture which tries to map morphology here with the molecular. And you can see that these lines are going in all directions. The stronger the line or the bolder the line, you have the stronger is the association. For example, if you have endometrioid carcinomas, FIGO grade 1 and 2, molecularly, most of them were no specific molecular profile. And on the other side, you can see your serous carcinoma. Most of the serous carcinomas were P53 abnormal. Now, what about clear cell? Clear cell molecularly could be actually anything. As you can see, the lines are going in all directions. And the most heterogeneous group was the endometrioid FIGO grade 3. And you can see it could be NSMP, it could be mismatch repair deficient, it could be polymutated, it could also be P53 abnormal. And that was the question which I think was asked repeatedly to Dr. Alina, that how do we differentiate them? So maybe let's see if we can do a few things now and you can understand the answer further. So this is WHO, the previous edition, and the 2014, which is the previous one, and the 2020. And the morphological subtypes were included in the 2014, whereas the WHO 2020 took cognizance of the molecular classification and classified them as per the molecular groups. But it still gives a lot of importance to morphology. It says the most important aim is to distinguish endometrioid from non-endometrioid. And I think all of you really described your tumors so well. I love the descriptions that you gave. You now know that the endometrioid looks like the proliferative endometrial glands, and the non-endometrioid just don't resemble them. So you could easily pick up the serous carcinomas described so well. You could pick up the clear cell carcinoma, and that is the whole aim. Your morphology needs to be absolutely perfect. And then, of course, you have problems sometimes with morphology, and that's when your IHC comes to help you to in that differential diagnosis. And you will also see subsequently that even your molecular can be done in your lab, and if you don't have it, you can outsource it. But so far, your fixation is good, your grossing is good, then your morphology will be good, your IHCs will work, and then subsequently, you can even send them or outsource them for your special IHCs that you would like to do, which you don't have in your laboratory. Now, as I said, the 4 molecular subtypes of endometrial carcinoma, the good news is that you have IHC surrogates for that. For the copy number high, which is the TP53 mutated subtype, you have a P53 IHC to help you do it. For the hypermutated group, which is the MSI high, you have your MMR IHC to help you with this. But for the polymutation, there is no IHC available, and you have to send it to a lab which performs this mutational analysis. So the role of the pathologist in the endometrial biopsy is to accurately type the tumor and to accurately grade the tumor. For this, you may require an IHC panel. In the elegant table which Dr. Alina showed you, you may need to do an ER, the least, a P16, P53, and you can start with a basic 2 panel for your MMR group. You can just start with PMS2 and MSH6. If any of them is lost, you can then do the other 2. But if both of them are intact, you are good to go that this is an MMR proficient tumor. In all cases, you may not be able to do that in your biopsy. You can, however, confirm it in your resection. In the resection specimen, your aim is to confirm your tumor type and tumor grade. You're supposed to stage it very accurately, and I'll quickly show you the staging parameters. And then your molecular subtyping may be done with a minimum of 3 markers, P53 IHC, PMS2 and MSH6. And for all these 3, the biopsy is preferred. And as Dr. Alina showed you, a HER2 testing is done, and it is indicated for P53 mutated cancers, which could be any type. Your serous carcinoma is P53 mutated, carcinosarcomas are P53 mutated, and as she described, your grade 3 endometrioids can be P53 mutated. And there is a subset of a low-grade endometrioid, which is P53 mutated. So any P53 mutated endometrial carcinoma warrants a HER2 testing. The guidelines are there in the CAP protocol. You may refer to that. The somatic mutation analysis of poly can be done by any of the methods. In our lab, we do it by Sanger sequencing, and it's done on the resection. It can be done on the biopsy. It is preferable, but it depends on how you would like to do it. And finally, when all this information is available, the risk stratification or the management is done by the clinicians. Now, this is your guidelines to risk stratify it into low, intermediate, high, intermediate, and high risk group when your molecular classification is not known. And the same applies when your molecular classification is known. And now you have an updated guideline in 2025. Don't be afraid of this table. I just want to tell you every single parameter on this is a pathological parameter, which means your clinician cannot do anything if you do not provide the pathological criteria absolutely pristine, absolutely accurate. Now, all these colors that you see, all these shades in these boxes are the various risk stratifications. Just to show you, light green is a low risk, which means no adjuvant therapy. Intermediate risk is this lemon box, which means the patient will get either vaginal brachy or no adjuvant therapy. Your high intermediate risk is this light orange box, which means the patient may get either external beam radiotherapy, vaginal brachy, or maybe no adjuvant chemotherapy as well. And a high risk is the one which mandates, radiotherapy, chemotherapy, immune checkpoint inhibitors, etc. So this entire management is dependent on the pathologist. So a lot of it rests on our shoulders. So these are the various staging parameters in your report where you have to report the tumor size because it may predict nodal involvement and recurrence, accurate histotype and tumor grade because it guides your adjuvant treatment, depth of myometrial invasion, cervical stromal invasion, uterine serosal and adnexal involvement all guide your staging. Parametrial and vaginal involvement guides your staging. Lymph node involvement with size of the metastasis guides your nodal staging. Biomarkers, MMR, P53, HER2 is used for Lynch syndrome, genomic subtyping, and treatment implication, as you can see with HER2 for trastuzumab and trastuzumab deruxtecan. And finally, you give the PTNM staging, which is an anatomical staging or a FIGO staging. And we will talk a little bit about the 2023 staging, which determines your adjuvant treatment. So LVSI has come in a big way in endometrial carcinoma reporting, where you call it no LVSI or focal LVSI when there are less than 5 vessels, or substantial LVSI when there are 5 or more vessels. And this is calculated or determined on a single H&E glass slide. The LVSI should be located at the tumor periphery and not within the tumor mass itself. Now, a quick recap into what you have learned. There are 2 types of low-grade endometrial carcinomas or non-aggressive endometrial carcinomas, and these are endometrioid, FIGO grade 1 and FIGO grade 2. As you can see, these are endometrioid type glands because they resemble your normal proliferative endometrium. And here there are no solid areas. So that is why this is a grade 1 endometrioid carcinoma. And this is your grade 2 endometrioid carcinoma, where the solid areas varies between 6 to 50%. You can club FIGO grade 1 and FIGO grade 2 as low grade. Okay. And again, this is resembling your normal proliferative endometrium. That's why this is endometrioid. Now, your high-grade endometrial carcinomas include FIGO grade 3 endometrioid carcinomas, which you just saw, a serous carcinoma, and a clear cell carcinoma. This is your FIGO grade 3 endometrioid carcinoma, where you can see the gland formation to the left and the solid areas to the right. Now, I want to draw your attention to the nucleus. The nucleus in the glands is similar to the nucleus in the solid area. So the same tumor is becoming solidified over here. Here, there is more than 50% solid growth. This is a non-squamous growth. Nuclei here are similar to nuclei here. There's some necrosis, and this is a grade 3 endometrioid carcinoma. Again, I want to draw your attention to the proliferative endometrial glands to which this resembles, therefore the term endometrioid carcinoma. And this is a very pretty clear cell carcinoma where you can see a tubulopapillary architecture, monotonous cells, small nucleoli, hyaline pores. This is your typical clear cell carcinoma. You can clearly see that this is not looking like your proliferative endometrium. So it's very important that on histology, you pick up your non-endometrioid morphology. This is the endometrial serous, which looks so pleomorphic, and in no way does this resemble proliferative endometrium. So this table was shown by Dr. Elena. This is when you have confusion, you can take the help of ER, PR, P16, P53, napsin, HNF1 beta, and racemase to distinguish your endometrioid from serous from clear cell. But morphology is the first thing that you need to take into account. So now coming to case 1, 66-year-old female who presented with postmenopausal bleeding. She underwent a TH-BSO at an outside center. The endometrial cavity showed a polypoidal fleshy mass, and the sections were submitted for review at our center. I would like any of you to start describing it without giving out the diagnosis. The first section, Dr. Neil, would you like to attempt this?
Yes, ma'am. So the section shows portions of biphasic neoplasm comprising neoplastic epithelial as well as stromal components. The epithelium appears to be arranged in a papillary architecture with few detached papillary cores, and the underlying stroma appears to be of sarcomatous differentiation with rhabdoid type of cells.
Excellent.
And these are cells with eccentrically pushed nuclei and abundant eosinophilic cytoplasm. And in this section, an area of heterologous differentiation in form of bony spicule is seen in the sarcomatous component.
What about this section, Dr. Neil?
Yes, ma'am. In this, we are seeing the solid sheets of the neoplastic sarcomatous component, and there was a bony spicule also of osteoid differentiation.
What about this section?
This section shows a few mitotic forms, including atypical ones, demonstrating the high-grade nature of
What are these
malignancy in the
cells?
stroma.
How do they look? How do these cells look? Can you
They look
describe any
rhabdoid,
details?
ma'am.
Very good. Excellent. So they look rhabdoid. So now for the online attendees and the students who are online, what is your impression? Dr. Neil has given a fantastic description. You can scan this QR code with your phones. And can you tell me whether this is a low-grade endometrioid? Is it a high-grade endometrioid? Do you think it's a sarcoma? Do you think it's a carcinosarcoma? And even if you don't know and you're not sure, you must attempt to do this. I would like some more people to attempt it. Whoever's online may please attempt this. Because this is the first poll, I'm going to wait for another 10 seconds, and then it'll get faster with the next subsequent polls. So we have around 20 participants, 18 participants. Okay. Right, 20 is a good number. Right. So the majority feel that this is a carcinosarcoma, and a minority, it's around 4%, feel that it is a high-grade endometrioid carcinoma, and some feel it is a sarcoma. Okay. So on immunohistochemistry, as Neil described, there was an epithelial component and a sarcomatous component. The epithelial component was strongly positive for cytokeratin, whereas this is the sarcomatous component, which was dead negative for cytokeratin. This is Vimentin, where the epithelial component was negative, but the sarcomatous component was strongly positive. And as described, the sarcomatous component was looking rhabdoid. So a Desmond was done, which was strongly positive, and a MyoD1, which showed strong nuclear positivity in the malignant sarcomatous component. So this was a carcinosarcoma with heterologous rhabdomyosarcomatous component. Now, I just want to tell you why this is not a high-grade endometrioid carcinoma. The reason is it doesn't resemble the endometrial glands at all. In fact, it looks so it is good enough to say that this is non-endometrioid to begin with, because it is not resembling the normal proliferative endometrial glands. So it's non-endometrioid, number one. It's got two components. It's got a malignant high-grade epithelial component resembling a serous carcinoma in the form of papillae, and it's got a malignant sarcomatous component resembling a rhabdomyosarcoma. Also, there was ossification, so it has malignant heterologous, two malignant heterologous elements, a rhabdomyosarcomatous component, and also like bony component. So this was a carcinosarcoma. This is your fourth high-grade endometrial carcinoma. FIGO grade 3 is one. Serous carcinoma is your second one, clear cell carcinoma is your third one, and your fourth high-grade endometrial cancer is a carcinosarcoma. These are not to be confused with sarcomas. These are actually a carcinoma which is showing a sarcomatous differentiation, and they are treated like carcinomas. So a carcinosarcoma is a biphasic endometrial carcinoma composed of a component of a high-grade sarcoma with or without heterologous elements, juxtaposed with a component of a high-grade carcinoma. And the most common one is a serous carcinoma, but it can also be a high-grade endometrioid carcinoma with it. You can have a clear cell carcinoma. You can have even an undifferentiated carcinoma as a carcinoma component. The key morphological features are that there is a high-grade carcinomatous component along with a malignant mesenchymal component, and there's often a sharp demarcation between the two, as you saw in this image. Now, do you really need IHC? I really don't think so, because you can clearly see the two components. So IHC plays a very limited role, and I showed you that you can use a combination of cytokeratin and vimentin. But if you have a specific heterologous element, for example, in this case, you can do desmin, myogenin, and MyoD1. Now, how much of the sarcomatous differentiation do you need to make a confident diagnosis of carcinosarcoma? So the volume has ranged from 2 to 25% in different studies, but the ISGIP recommends that you can measure it at least 1 millimeter in one dimension of the sarcomatous component should be there. Call it a carcinosarcoma. Now, this is an arbitrary figure that is not evidence-based. It reflects the view that even a minimal sarcomatous component should not result in a diagnosis of carcinosarcoma. At least 1 mm should be there. So that is the criteria. Now, is it important for you to split hairs and say, well, the epithelial component is so and so, and then the sarcoma component is so and so that you can, or is it okay just to say carcinosarcoma? Actually, it's quite okay to say on morphology what you think it is. If you have a malignant epithelial component and a malignant sarcoma component, you're good to call it a carcinosarcoma. But the sarcoma component can be of two types. It can be a homologous type or a heterologous type, and this is only for academics. That the homologous type means where the mesenchymal component is intrinsic to the uterus. For example, if you have a stromal component or a leiomyosarcoma component, it is intrinsic to the uterus. It's a homologous type. Heterologous type is when the mesenchymal component is extrinsic to the uterus. For example, in this case, a rhabdomyosarcoma or an osteosarcoma or a chondrosarcoma component. That will mean it's a heterologous elements. Accurate subclassification of the sarcoma component is a useful academic exercise, but is not relevant to management. Now, coming to case 2, 62-year-old female postmenopausal bleeding underwent endometrial aspiration biopsy at an outside center where it was called endometrioid carcinoma FIGO grade 3, which means there must have been solid areas more than 50%. The sections of the biopsy were then submitted for review at our center. So would anyone like to attempt this case? Anyone can do this. Sanjana, Chaitra, Nangsan, Manya, Anurathi, Ishan. Anyone? Neil, back to you. Would you like to attempt it?
Yes, ma'am, I'll try.
Sure.
Section shows section shows endometrium with portions of a neoplasm. The endometrium on the right side, it appears bland and benign, whereas the neoplastic component appears to be stromal, I would say.
Okay. I'd like to stop you right here, Neil. I'd like to stop you. Why are you calling this benign?
Because the cytological atria, I wasn't sure of
Do
that.
you see
That's
any
why.
stroma in between these glands?
No, ma'am.
You don't. So these are back-to-back endometrioid or non-endometrioid. What do you think this is? This is the
Endometrioid, yeah.
gland-forming component. What do you think it is?
Endometrioid with solid component. Okay.
Yes. So this is, now look at this normal proliferative endometrium, proliferative endometrial glands. And what is this in between? This is just a
Stroma.
comparison. Stroma. So this is just your normal endometrial stroma. Do you see any stroma in between these glands?
No, ma'am.
So what happens when you have back-to-back endometrioid type glands? What is that equal to?
Endometrioid carcinoma, we would call it.
Sorry, can you be louder?
Endometrioid carcinoma, ma'am.
Excellent
We can
answer.
call it.
So when you don't need desmoplasia or an infiltrative pattern to call it endometrioid carcinoma, and this is something I try to explain to my fellows as well, that you don't need that. When you have confluent back-to-back endometrioid type glands with stromal exclusion, means no stroma in the middle, you can have fibrovascular stroma, but no endometrial stroma. These stromal cells, can you see in between these glands? Can you see it? You cannot see. You can see some inflammation and all that, but you can't see any endometrial stroma. So that is why this is a back-to-back endometrioid type glands. Confluent pattern is equal to an endometrioid carcinoma. And as you rightly said, this looks low grade because in this area, there was no solid area. In this particular image, at least you don't see a solid area. What about the area next to this? This area.
Yes, this appears solid.
It's a solid sheet. Can you see any
Yes.
endometrioid type glands here?
No, ma'am.
Can you see any spindle cells here? Can you see spindle cells here?
No, ma'am, but when I originally saw, I was confused between whether these are stromal neoplastic cells or whether these are endometrial cells.
Okay. No, that's a very valid point. So yes, as someone wrote in the chat box, they're looking round. Are these round cells stuck to each other or they are discohesive?
They are discohesive.
Very good. Does the nucleus of this cell look like, there is some cytoplasm, someone is saying, okay, but these are discohesive cells with some spaces around them. And does the nucleus of this nuclei look similar to the nucleus of the endometrioid type? I'm going back. The nucleus here, does it look like the nucleus here?
No, no.
It doesn't. This looks more hyperchromatic, discohesive. There are these spaces around it, and this nucleus looks more vesicular and oval. So the nuclei of these two are different. Does it look endometrioid? Next question.
No, ma'am.
No. Okay, very good. So someone mentions that this is looking like a PNET or looks like an ARMS. So they are feeling this looks like a round cell tumor. Does this look like a round cell tumor to you?
No, ma'am, it's not closely packed. It's very discohesive. So
Discohesive. Okay. So what is your impression? Let everybody say, does it look like a high grade FIGO grade 3 endometrioid carcinoma where you have a solid area and gland forming area, solid area more than 50%? Does it look like a non-endometrioid carcinoma, the whole thing? Does it look like a dedifferentiated carcinoma, or you're not sure? So I would like you to again participate in the poll. And I think now that you have the QR code, you will be it'll be quite quick. It's going to come on your screens faster. I'll go up till I think 20, 25 polls and then I'll stop. Okay. So a majority feel again that it's a dedifferentiated carcinoma. Some of you feel, and it's a very valid differential, that you feel it's a FIGO grade 3 endometrioid carcinoma because there are solid areas more than 50%. And some of you feel this is non-endometrioid, which is also fine. But I'm glad that most of you have an idea what this is. So I'll move on. This is the endometrioid carcinoma component, it was strongly ER and PR positive. The endometrioid carcinoma component was showing loss of nuclear staining for MLH1 and PMS2, but MSH2 and MSH6 were intact. I don't have the picture. I just have the pictures for the loss. So why is it a loss? Because you can see that the nucleus is not staining, but your internal control, which is your some amount of your stroma was here, is showing the staining, or your inflammatory cells. These are inflammatory cells. This acts as your internal control, and you know that your stain has worked. So this is MLH1, PMS2 loss, MSH2, MSH6 intact. The undifferentiated component, however, no staining for ER and PR, very focal staining for CK, and no staining for Paxate. And it showed ecadherent loss, BRIG1 loss. So this was the undifferentiated carcinoma component. And even that component showed a loss of MLH1 and PMS2, whereas MSH2 and MSH6 showed intact nuclear staining. And in the loss area, you always have to compare it with your internal control. So what is this? This is a dedifferentiated endometrial carcinoma, and this is your 5th type of high-grade endometrial cancer. So undifferentiated and dedifferentiated carcinomas are, something similar, but there are some differences also. Now, an undifferentiated carcinoma will have only your round cell pattern, solid pattern of round cells showing no epithelial differentiation whatsoever, except by IHC, you'll see some CK and EMA expression. It's a very difficult diagnosis to make because a lot of things enter your differentials, and I can see the chat box flooding. You can think of right from a undifferentiated carcinoma to a lymphoma to a PNET to a RMS to so many different differentials come into your mind. But a dedifferentiated carcinoma is somewhat easier because it is an cancer along with a low-grade endometrioid carcinoma. It's just lying next to it, which makes it easier to make this diagnosis. Because in this particular case, Neil really well picked up the low-grade endometrioid carcinoma component. It is very easy to say what the neighbor is. So these undiff, D-diff cancers represent 10% of high-grade endometrial carcinomas and 2% of all the endometrial carcinomas, and they are aggressive tumors. So undifferentiated is a monomorphic neoplasm composed of only those small cells or intermediate cells in sheets without any obvious glandular differentiation, and it's got a discohesive pattern at low power. It is so discohesive that you start thinking whether it's a lymphoma or a plasmacytoma or a high-grade ESS or even a small cell carcinoma. Now, a D-diff cancer is going to have a low-grade endometrioid carcinoma in its neighbor, and along with it, an undifferentiated component. Okay? All right. Now, the majority of the undifferentiated or that round cell component will show you lack of Paxate, ER, and PR, but 20% can show some focal staining. P53 is usually of the wild type, but can also be mutated. 80% of the undifferentiated component will show you some amount of epithelial differentiation in the form of EMA or CK. You can also see some synaptophysin or chromogranin, which are neuroendocrine markers in this undifferentiated component, but it is going to be in a minority, only up to 10%. So be careful, don't call it a neuroendocrine carcinoma. 50 to 75% of these tumors show MMR deficiency. As you can see, this case was also MMR deficient. MLH1 and PMS2 showed loss of nuclear staining, and they are associated with inactivating mutations in the SWI/SNF complex, manifested on IHC by loss of BRIG1, sometimes by loss of INI1, and there's loss of ARID1A or ARID1B. So the differential diagnosis, and many of you said this was a grade 3 endometrioid carcinoma, which is a very, very valid differential diagnosis. And I'll show you how you can differentiate, because that's the most common confusing diagnosis. You may think, is this a serous carcinoma with a solid architecture? These will be P53 mutated and MMR proficient, mind you. Lymphoma, plasmacytoma, melanoma, high-grade ESS, high-grade neuroendocrine carcinoma will come into your differential when you don't see a low-grade component in its neighborhood. And that if it's solid sheets of those cells, yes, these are very important differentials, and it will warrant a lot of IHCs to distinguish all these from each other. So this is one, an undiff carcinoma is one carcinoma where on morphology, you will only be able to call it small round cell, maybe on an HNE, and this will warrant immunohistochemistry. But if you have a low-grade carcinoma next to it, then your differentials really narrow down between a grade 3 endometrioid carcinoma or maybe a carcinosarcoma where the round cell component you're thinking is an RMS. So then your differentials will be lesser. Okay. So let us look at how will you distinguish a FIGO grade 2, grade 3 from a dedifferentiated one. Will you get a diffuse sheet-like growth in an endometrioid FIGO grade 2, grade 3? Most likely no, but in a dedifferentiated, you're going to get it. In a endometrioid grade 2, grade 3, you'll see some intermingled glands. In a dedifferentiated, you'll see a sharp demarcation between the two. Squamous differentiation will be seen in endometrioid FIGO grade 2, grade 3. In dedifferentiated, you'll see abrupt keratinization. In your endometrioid grade 2, grade 3, the solid areas will not have discohesive cells, but in a dedifferentiated, you're going to have discohesive cells, which will manifest as an ecadherent loss. The ecadherent will be retained in the solid areas in your endometrioid grade 2 and grade 3. A rhabdoid cytoplasm will not be seen in the solid areas in endometrioid grade 2, grade 3, whereas in a dedifferentiated, you may see some rhabdoid looking cells also in the round cell area. I showed you the nucleus when we were discussing grade 3 and grade 2 endometrioid carcinomas. Remember, the nuclei are similar because it's just the same nuclei of a gland which is becoming a solid area. So this is your endometrioid grade 2, grade 3, but the nuclei are similar in the gland forming area and similar in the solid sheets. Whereas in a dedifferentiated uterine carcinoma, the nucleus are different. They start looking like round cells and they are different from the glandular area. You may see necrosis in both, but you can see more necrosis in dedifferentiated. Your cytokeratins, cytokeratin CK, 7 and CK will be more diffuse in your gland and your solid area in your FIGO grade 2, grade 3. But in your dedifferentiated, the cytokeratin 7 plain cytokeratins may be reduced in those dedifferentiated areas. PAX8 will be strongly positive throughout in your gland and solid area in endometrioid grade 2, grade 3. In dedifferentiated, your PAX8 will be lost or maybe focal in your solid areas. And then ecadherent, BRIG1, INI1 are your other markers which are going to help you. And your MMR also is going to help you. So this is your grade 3 endometrioid carcinoma. Look at the nucleus here and the nucleus here. It's almost identical. And both are looking endometrioid in nature. Here, this is your dedifferentiated carcinoma, where the nucleus here is different from the nucleus in the gland forming area. So carcinosarcoma versus dedifferentiated is another very important differential. In carcinosarcoma, the epithelial component is usually a serous carcinoma. In dedifferentiated, the epithelial component is usually an endometrioid carcinoma. In a carcinosarcoma, the sarcomatous component usually has pleomorphic spindle cells, whereas in a dedifferentiated, the solid area usually has discohesive monotonous round cells. But mind you, rhabdomyosarcomas also can look like round cell tumor. So this is sometimes you definitely have to do a Desmond myogenin and MyoD1 in this case. Heterologous elements are common in carcinosarcomas. They are not common in dedifferentiated uterine carcinomas. And loss of MMR protein is more common in dedifferentiated uterine carcinomas and less common in carcinosarcomas. So again, this is your dedifferentiated carcinoma showing only the undifferentiated area here. And this is your carcinosarcoma. Here is your malignant epithelial component. This is your spindle cell component. Here you have your malignant cartilaginous component. Coming to case 3, it's a 49-year-old female, a case of carcinoma endometrium, post-TH BSO at an outside center in 2017. And for this, she received adjuvant radiotherapy. Then she underwent a right lung lower lobectomy because she developed lung metastasis somewhere outside in 2019, for which she received adjuvant chemotherapy. And at that point, she came to our hospital showing a mass in her lower anterior abdominal wall in the midline. And this was measuring around 4 into 3 centimeters. I sent you sections of wide local excision of the abdominal wall mass. So this is a low power view. Would any of you like to take this? Any of you may take it?
Yes, ma'am. I'll try.
Yes, please, Neil. Please carry on. You'll get a prize at the end for attempting all.
Okay, ma'am. So this section shows 5 diagnosed tissue with portions of an invasive neoplasm. Arranged, there are multiple patterns. First, predominant, we can see cystic spaces, which are lined by endometrioid, neoplastic endometrioid type cells. And as well as on the right side of the screen, we can see more closely packed endometrial glands, which are more back-to-back arrangement with little intervening stroma in between. This is one of the cystic spaces with the lining epithelium. Here we can see it's of endometrioid type with elongated cells. Some exhibit pseudostratification as well. The pleomorphism is mild, and the based on like
No, I don't want the diagnosis. So you've
okay.
Over here, what is the what sort of
This is one willow glandular kind of a pattern here.
Okay, good. So I like the description. And what do you see in this lumen? What is this?
Some eosinophilic secretions are there along with some
Excellent.
inflammatory infiltrates.
Very good. So you see the very nice. So I'm going to describe it now. So as he described, there are two patterns. You can see some cystic areas and you can see some solid areas. I also want to draw your attention that this looks like a very, very blue tumor. And then when you go higher, you see a variety of patterns. The cystic areas are lined by tubules, by glands. Then there are some papillae. And these are lined by very blue cells. By blue, I mean there is very more of the nucleus, less of the cytoplasm, and they look like slit-like spaces here. Very blue nuclei, and some of them have some nuclear clearing also. And then there is some intraluminal secretions. So, what is your impression? Students as well as online attendees, I would love you to attempt this. Do you think this is a low-grade endometrioid carcinoma? Because this was predominantly, as you can see, there were glands and some papillae. There were some solid areas, but not that many in the images. How many of you feel this is a high-grade endometrioid carcinoma? How many of you feel that this is okay, a non-endometrioid carcinoma? It is not resembling your normal proliferative endometrium. And how many of you are not sure with this? So I'm going to wait for at least 20, 25 people who have attempted it, make it a reasonable amount of poll to see what is the distribution. I will encourage all of you to participate, whoever is there online. Just scan the QR code and put in your option. Waiting just for a few more. Don't be shy, just attempt. Okay, I think we'll stop at this. So we have a divided house, 63%, but the majority feel this is non-endometrioid, and that's brilliant. And a few feel it's a high grade, but endometrioid carcinoma. Some feel it is a low grade endometrioid carcinoma. A minority don't know, which is totally fine because you don't have your IHCs. But what is very important, and I want you to take this image back home, it's a solid and a cystic. I mean, it's a tumor showing some solid areas. I don't mean solid sheets, but some tight areas and some cystic areas. Cysts are lined by very blue-looking cells forming a variety of patterns, glands, papillae, sieve-like patterns, slit-like spaces, and the nuclei are moderately pleomorphic. I won't say they are very pleomorphic like a serous, and it's a very blue tumor because there's very less cytoplasm. There's more of the nucleus. Some of the nuclei are showing nuclear clearing and very prominent intracytoplasmic secretions. And I would love to show you them at low power itself. You can see all these secretions, okay? So the immunos, PAX8 strongly and diffusely positive, ER and PR dead negative. So as you saw, for the distinction of to call something endometrioid carcinoma, you need ER and PR. So where is your ER and PR? So though it does resemble your endometrium or the proliferative endometrial glands to an extent, but not completely, where is the ER and PR? And this tumor was strongly positive for GATA3 in some areas. And where it was negative for GATA3, it was positive for this particular marker called TTF1. So this was a abdominal wall mass which was involved by a mesonephric-like carcinoma of female genital tract origin. So when you go to your WHO, there is a section called Other Endometrial Carcinomas. Mesonephric adenocarcinoma is an adenocarcinoma arising from mesonephric remnants. But in the uterus, you don't have mesonephric remnants. So in the uterus, it is called a mesonephric-like adenocarcinoma because it resembles mesonephric differentiation. And in the cervix, where there are mesonephric remnants, it is called a mesonephric carcinoma. Okay, so this was the next type of high-grade endometrial cancer. This is not a low-grade endometrioid carcinoma. It's a deceptively bland-looking tumor. It's a pitfall, and you must be aware. The features are a very blue appearance, the fact that it has metastatized to the lung, now it's coming with abdominal wall metastasis. A low-grade endometrioid carcinoma does not do all this. It's a blue-looking tumor. It's got a variety of architecture. It's got intraluminal secretions. It has got a moderate nuclear pleomorphism. It's got some nuclear clearing. This resembles a mesonephric remnants, but it does not arise from mesonephric remnants because they are not there in the uterus. So this is a mesonephric-like adenocarcinoma involving the abdominal wall mass. So what is a mesonephric carcinoma and what is a mesonephric-like adenocarcinoma? Mesonephric carcinoma arises from mesonephric rests in the cervix, and it is there it's called a mesonephric carcinoma. In the uterus and in the ovaries, you don't have mesonephric rests, so they are mesonephric-like. They are said to arrive or derive from Mullerian remnants, okay, and they are Mullerian in origin. Now, the typical feature is small tubules, slit-like features, sieve-like architecture with dense eosinophilic colloid-like material, and as I said, a very blue tumor with an array of morphologies: papillary, ductal, retiform, solid, sometimes even a spindled architecture. And this is a very, very new paper called the MLA Diagnostic Criteria and Controversies, and it addresses all the problems which can arise when you are encountering such a neoplasm. And this is one neoplasm where you would require IHC, because if you didn't do it and you called it a low-grade endometrioid, this is a very aggressive tumor, and as you saw, this had spread to the lungs and later it also recurred in the abdomen. So if you call it just a low grade in the beginning, it may not receive any aggressive therapy and it's going to come back in a very bad way. So it is very important to recognize it first by morphology, to suspect it, and then apply immunohistochemistry. So molecularly, these show KRAS mutations in the majority. And because, as I said, they derive or they arise from Mullerian origin, some of them also show some ARID1A, PIK3CA, PT, P10, etc. Interestingly, they do not show any poly mutations or P53 mutations or mismatch repair deficiencies. In case you get a tumor which looks like this but shows mismatch repair deficiencies or shows P53, you're possibly not dealing with this. You should confirm and then go a step ahead. You should do the molecular testing and see if there is KRAS or anything, and then you should make a diagnosis of mesonephric-like adenocarcinoma, because it is an aggressive tumor and it is a very serious diagnosis to make. Now, as I said, how will you distinguish a mesonephric adenocarcinoma of the cervix from a mesonephric-like adenocarcinoma of the uterus? Morphologically, immunohistochemically, they are identical. The only difference is that mesonephric remnants are there in a mesonephric adenocarcinoma of the cervix, and in the uterus there are no mesonephric remnants. Molecularly, because they arise from mesonephric remnants in the cervix, the cervical tumors show only KRAS and /NRAS, whereas in the uterus, because they are of Mullerian origin, they show KRAS predominantly but can also show these other Mullerian mutations. So This is a difficult diagnosis. Sometimes it's overdiagnosed. Cases are there with challenging morphologies, and one must show to an expert, or you should show it to a higher center when you're making such a diagnosis, especially when you don't have TTF1 or GATA3, or if you have a non-classical molecular profile. That is, if you have a P53 mutant or a MMR deficient tumor and you want to call it mesonephric, please be careful. And in the lung, remember, these tumors, when they metastasize, these tumors show TTF1. So don't call it a lung primary then, because TTF1 is also seen in lung adenocarcinomas. So if a patient has a history of an endometrial carcinoma and now is metastasizing to the lung and there it's showing TTF1, make sure you do a PAC-SATE and you confirm that this is not a mesonephric like spreading to the lungs before calling it a lung primary. So these are some, it's a difficult diagnosis, but there are papers, and this is the paper which I showed you, which will help you. And of course, you should seek some advice before calling this tumor an MLA. The next case is a 60-year-old female postmenopausal bleeding. Endometrial biopsy is called, and high-grade endometrial carcinoma outside. A cervix biopsy was done, which was negative for malignancy. The patients had a normal cervix and a vagina. Endoscopy and colonoscopy were normal. And this is a section of the endometrial and cervical biopsy, which was submitted. So anybody wants to attempt this endometrial biopsy? I don't know how many of you are still online, but I will take just another 20, 25 minutes more. So that's okay. Neil, would you like to attempt this?
Yes, ma'am.
Sure.
Section shows endomyometrial tissue with portions of an invasive neoplasm, neoplastic endometrially cells which are arranged in predominantly, the neoplastic ends are kind of enlarged. They have tubular to microcystic architecture, and some of the these glands have intraluminal, many intraluminal exudative material is also seen, and intervening stroma is scanty with then much inflammatory exudates.
What about this?
Here, this is necrosis.
Very good. Very good.
Extensive
Excellent.
necrosis.
What does it look like to you here? What does it remind you? This part. What are these? Anybody wants to put it in the chat box? What do you think these are? Colonic. Excellent. So this was the cervix. They are goblet cells. So as Neil described, there are glands, there are cribriform structures, there is this garland type of necrosis, there are these garlands, dirty necrosis, and then there are these goblet cells. What about the cervical stroma and the endocervical glands? How does it look, Neil?
The cervical stroma appears edematous and kind of.
Is it malignant?
The glands are. No, ma'am. The endocervical glands appear bland.
They look bland and there is nothing in the cervical stroma. So the cervical biopsy looks negative. Okay. So what is your impression? Is this a low-grade endometrioid carcinoma? Is this a non-endometrioid carcinoma with intestinal or colonic morphology? Is there involvement by a colon tumor? Remember, the colonoscopy of this was normal. You're not sure or you don't know, which is perfectly fine. So I would just encourage you to scan and to attempt it, because it's a great exercise to try to tickle your gray cells. I know it's dinner time. Keep munching and keep participating. I'll wait for around 25 participants. No, the preliminary results look that the majority feel that this is a non-endometrioid carcinoma with an intestinal or colonic morphology, which is great. And a minority feel that this is involvement by a colon tumor, which is super. The great news is that many of you don't think that this is a low-grade endometrioid carcinoma, which is wonderful. And I'm so happy that all of you are kind of know which zone you are in. So remember I said colonoscopy was normal. There wasn't a mass, which is, so that is there. So this was a PAX8, a monoclonal PAX8, which was done, and it was showing some, not that strong, but it was showing some patchy positivity. The tumor was dead negative for ER and PR, and P16 was of a non-block type. And the minute you see that the ER and PR is negative, you should think that this is not an endometrioid carcinoma, just like it's a non-endometrioid. Just like the mesonephric was also ER and PR negative, this is also ER and PR negative. And therefore, these tumors do require an IHC confirmation. So morphology definitely is important, but there are tumors which, and particularly these ones, which require an IHC for you to be sure. This tumor was strong diffuse positive for CK7, patchy positive for CK20, and strong diffuse positive for CDX2. So this is a summary of your IHC. CK7 strong diffuse positive, CK20, CDX2 strong diffuse positive, CK20 focal, PAX8 patchy, I would say. The important negative markers, ER and PR, negative, P16 non-block, P53 wild, GATA3 because of the experience from your mesonephric tumors, GATA3 is negative. There's no napsin, so, and anyway, it didn't look like a clear cell, and Vimentin was negative. So the diagnosis was, this is an adenocarcinoma with a gastric or an enteric or a colonic differentiation. Favor an endometrial origin. In view of the unusual morphology and IHC, please rule out a primary in the gastrointestinal tract before considering an endometrial primary. But I told you earlier, endoscopy normal, colonoscopy normal. This patient, and this is way back, this is not a, this was around 2021, when this case was diagnosed. But this is a TH-BSO was done with a pelvic and a para-aortic lymph node dissection with omentectomy. And the reason was we didn't call it an endometrioid carcinoma. So that is why a full staging surgery was done in this case. And the tumor, if I showed you here, looked just like the biopsy, in fact, more colonic than what it was looking in the biopsy. So if you go to your section of other endometrial carcinomas, you will see that there is a primary gastric or a gastrointestinal type of mucinous carcinoma in the endometrium under your heading of other endometrial carcinomas. So this was an endometrial gastric type of adenocarcinomas, and this is your next type of high-grade endometrial carcinoma. And on staging, this was invading less than half of the myometrium, so it was a PT1A. All the nodes were negative. There was no LVSI. Because there was a presence of a gastric morphology and goblet cells, and there was no other evidence of the primary site. There was no typical endometrioid component. There was no cervical glandular or stromal involvement. Because remember, there is also a gastric type of cervical cancer. So which is a non-HPV mediated cancer. So gastric type of cervix is also a very important differential diagnosis. In this case, I showed you the cervical biopsy in the beginning. The cervix was not involved. These tumors should show at least some focal expression of a gastrointestinal marker. Our case showed focal CK20 and a very strong CDX2. We didn't have a MUC6. And there should be absent or minimal expression of ER and also PR. Both our ER and PR were dead negative. So why is it important to recognize this tumor? Firstly, you have to exclude a cervical gastric type of cancer. If you have a cervical gastric type, you're probably dealing with a cervical gastric type of adenocarcinoma invading the uterus. You have to exclude a gastrointestinal tract origin, and some of you also called it colonic, which was absolutely correct. You have to rule it out. And this was ruled out right in the beginning by doing a colonoscopy. The tumor cells are typically negative for ER and PR. Therefore, you cannot call it an endometrioid with mucinous differentiation. Remember, Dr. Alina showed you endometrioid carcinomas can show mucinous differentiation, but they will be ER and PR positive even where there is mucinous differentiation. This is not an endometrioid. This is ER and PR dead negative. and it is showing a cribriform like areas. It is showing dirty garland necrosis. It's showing goblet cells. So this is a gastrointestinal type where the Paxate is positive, ERPR is negative, and it is showing gastrointestinal markers in the form of CK7, CK20, and even CDX2. Now these tumors behave very aggressively. They can show KRAS mutations and should not be misdiagnosed as a low-grade endometrioid carcinoma. Coming to case 5, 71-year-old female, postmenopausal bleeding, underwent THBSO, bilateral pelvic lymph node dissection at an outside center. So we also get review cases at our center where the entire operation is done outside and then they come to us for further management. Now outside, it was called endometrioid carcinoma, FIGO grade 2, and the slides and blocks were submitted for review. Now, I'm not going to ask for any participation in this because it's kind of late and I'm going to rush with the cases. So this is showing these glands which have a lot of a cytoplasm in them, but there's a lot of necrosis. If you look at these nuclei, they are not very pleomorphic and they do resemble a little bit endometrioid type glands, but they have a lot of cytoplasm. And there is some mucinous change as well. And there are lots of tumor infiltrating lymphocytes here. Here it's resembling normal endometrioid. And here there is a lot of dirty necrosis. And it does resemble endometrioid over here. Okay. There's intact nuclear expression of MSH2 and MSH6. You can see the nucleus is all intact. And this is your internal control in the form of some stromal cells and inflammatory cells. And this showed loss of nuclear expression of PMS2 and MLH1. So this was MMR deficient. P53 was wild. Poly was also wild. So the final diagnosis was an MMR deficient endometrioid carcinoma. PT1B because it showed more than 50% myometrial invasion. So if you look at the molecular classification and the with known and unknown, both were available with us. It was a stage 1B mismatch repair deficient endometrioid carcinoma. You can place it here. It comes in the intermediate risk group. What is the treatment for intermediate risk group? It's not a pole E, so it is a stage 1B. The treatment is Wald brachytherapy and no chemotherapy was given. As I showed you in the initial boxes, that if it falls in the intermediate or the high intermediate risk, they are not given chemotherapy. So that's a very important thing for you to note. Now, a little bit about the biology of mismatch repair. Before a cell divides, you know, it has to replicate its DNA, producing an identical copy for each daughter cell. So 3 biological processes govern the accuracy of DNA replication. The first one is an accurate selection of the correct DNA bases at each position, which is carried out by polymerase portion of DNA polymerase. So the DNA polymerase makes sure that A binds to T or adenine binds to thymine and cytosine binds to guanine. So there has to be an accurate selection of the correct DNA bases. Then there is a proofreading which is done to make sure that there is no wrong things happening. For example, A should bind to T and not G with T. So it's very important that proofreading is done, and this is carried out by the exonuclease domain of the DNA polymerase. Now, what is repetitive basis? So there are some segments of repetitive bases within the DNA strands. They are short tandem repeats of the same repetitive DNA sequence, and these are called microsatellites, and they are present throughout the genomes. Because there is a repetition, whenever you repeat something, like if I ask you to repeat A, if I ask you to repeat something, there is a high chance that there's going to be a miss. One A may go because it's repeating so many times. So there is a high chance that there is going to be an error. So what are these errors? There can be, because in this repetitive sequences or microsatellites, there can be a base-to-base mismatch error. There can be an insertion error. There can be a deletion error. And this is your mismatch repair deficiency. Now, thankfully, even to correct these errors, there is a post-replication correction, which is carried out by the MMR system. And these are a set of 4 proteins, MLH1, PMS2 pair together, MSH2 and MSH6 are a couple. And they recognize these mismatches, and they target them for excision, for accurate resynthesis, and then ligation. Now, if you have a defective MMR, the cell becomes prone to get a large number of errors or large number of mutations, and this leads to cancer. So this is a basics of your mismatch repair. Therefore, in endometrial carcinoma, you have two important mechanisms. One of carcinoma, one is the mutation in the proofreading part only, which is there in the exonuclease domain of the pole E, and this forms your basis of the pole E testing, or there is a mismatch repair defect. This whole mechanism which checks these defects is gone, and this forms the basis of your MMR and MSI testing. So MMR deficiency has been described in 20 to 30% of endometrial carcinoma. Now, the majority of them are because of a somatic change, which is a methylation or a silencing of the MLH1 promoter region of the MLH1. And the majority of them are actually somatic. Only 5 to 6% are associated with a germline condition, which is your Lynch syndrome. So why should we do MMR in all the cases? Number one, MMR deficiency, if you get, it's a marker of endometrioid type of endometrial carcinoma. If you get MMR deficient, most of them are endometrioid type. Remember, I showed you an MMR deficient in a dedifferentiated carcinoma. What is dedifferentiated? You have a low-grade endometrioid, and then it's becoming dedifferentiated. So, and I showed you this tumor. This was strong ER/PR positive, and it was also MMR deficient. So these are endometrioid tumors are the ones which are generally MMR deficient. So if you get MMR deficiency, most likely you're dealing with an endometrioid tumor. MMR is associated with, and as I told you, this deficiency in 5 to 6% with Lynch syndrome. So it's very important to identify families. And as Dr. Alina mentioned, these patients present as with endometrial carcinoma as their first cancer, as a sentinel cancer, and then subsequently can develop colon cancer. So you can screen these families for the subsequent cancers, and it's a great boon to have this MMR IHC. It's prognostic as identified by the molecular classification. It's got an intermediate prognosis, and these patients, it's got a predictive value also. You can give them immune checkpoint inhibitors when they recur. So these are the important things of doing an MMR IHC in all cases. What is MSI testing? It is sometimes used. MSI testing is when you are testing doing a PCR test, and MMR testing is done on an IHC based test. Okay, so it is a little different. Both MMR and MSI testing have 96% concordance, and MMR IHC is the more cheaper and easily accessible method, and because you correlate it with morphology, and it's a better method to do because it's available in our labs. Okay, you can start, because they occur as couples, you can start with a 2 IHC approach to be a little to conserve your costs. So you can start with the PMS2 and the MSH6, and if one of them is lost, you can then subsequently do the other two. But as a screening method, you can start with just these two rather than doing all 4. Now, all 4 are tested, or you can just start with 2. If there is intact nuclear staining, it is mismatch repair proficient and not deficient. If it is deficient, then it is easily, all this information is available in your CAP protocols, and you know that if you have MLH1 loss and PMS2 loss, most commonly it is a somatic event of MLH1 promoter methylation. Very minor of them is because of a gene defect. But the other losses are almost genetic basis they have and are associated with Lynch syndrome. Now, the method is that you test all the endometrial cancers for MMR. If you have the loss of MLH1 and PMS2, you first do the MLH1 promoter hypermethylation testing. If it is detected, you know it's not Lynch syndrome. If it is not detected, then you're possibly dealing with Lynch syndrome. And your other MMRs, if they are lost, you do a genetic counseling, and this is maybe a Lynch syndrome. Coming to the next case, 61-year-old female postmenopausal bleeding, underwent THBSO, bilateral pelvic and para-aortic lymph node dissection in 2022, an outside center. So I'm talking almost 4 years ago, where it was called endometrioid carcinoma, FIGO grade 3, and the slides and blocks were submitted for review. I'm going to describe it to you. In some areas, if you will agree with me, it did look very endometrioid. It's looking endometrioid, but a little bizarre in some places. For example, here it's looking a little pleomorphic, but otherwise it does look endometrioid. Now, does it look endometrioid? Not really. It's beginning to look quite pleomorphic as you look. Some solid areas, maybe it's a grade 3, I don't know. But here it is not looking endometrioid at all. It's beginning to look very pleomorphic. Here there are some squamoid areas, some clear cell-like areas. So it's looking different in different parts of the same slide. Here the nuclei have become very prominent nucleoli, very bizarre nuclei, as you can see. Mitotically very active. I don't know, it's looking quite bizarre in this. Some tumor giant cells are also here. Look at the mitotic figures. Some intratumoral neutrophils are there. And this was the one involving the endomyometrium, again looking very bizarre in this particular area. Look at the tumor infiltrating lymphocytes. This is a section from the cervix, and you can see this is the endocervical glands, and the tumor is invading the cervical stroma. To call cervical involvement, the tumor should not only colonize the glands, cervical stromal involvement is very important. Just glandular involvement is not sufficient. Tumor should invade the cervical stroma. As you can see, these are endocervical glands, and you have the tumor right beside it in the cervical stroma. So you know that this is a true cervical involvement. So the key histological features were there was intratumoral heterogeneity. Was it really mixed, or was it just ambiguous? Different areas looking different. Can we really classify the tumor on morphology? Very difficult. You can't really call it endometrioid grade 3. It was looking rather ambiguous. Patchy bizarre atypia, tumor giant cells, mitotically active in many areas, prominent tumor infiltrating lymphocytes, peritumoral lymphocytes, and intratumoral neutrophils also. The tumor was strongly and diffusely positive for ER and PR. P16 lacked block positivity. P53 showed a wild type of staining. All the MMR IHC showed intact nuclear staining. It was MMR proficient. On the final diagnosis in February 2022, it was called endometrioid endometrial carcinoma because ER and PR was strong positive, like an endometrioid should be. P53 was wild, and the tumor invaded the cervical stroma. All the lymph nodes were negative, so it was called FIGO grade 3 PT2N0. So in March 22, this was the final diagnosis that it was MMR proficient, P53 wild, endometrioid carcinoma, FIGO grade 3. And because of this, it was decided it was high intermediate, and it was decided that this patient probably needs chemotherapy because at one point there was also a doubt whether this was P53 mutated. And the patient was planned for chemotherapy followed by radiotherapy. And then she was followed up and one cycle of chemotherapy was given. At that point in 2022, we were validating our poly test, and this was one of the first samples that we suspected could be poly mutated, and it was positive for missense variant at exon 9, and it was actually a poly mutated tumor. And if you see in this graph, a poly mutated tumors have excellent prognosis. If you have a poly mutation, it means it's a poly ultra mutated endometrial cancer. It implies it's not a serous carcinoma, it's not a grade 3 carcinoma, and it has a very favorable clinical outcome. And if you now put it into this risk category, because it was first called high intermediate, now you know it is a stage 2 poly. Look at how the prognosis changes. From a high intermediate, it became a low risk tumor. And what do you do for low risk tumors? I showed you in the beginning. You just follow them up. So this patient, further chemotherapy and radiotherapy was deferred. This patient is doing very well despite the horrible morphology that you saw on the last follow-up, which was very recent in May 2026. So what is the poly testing? I'll just give you a brief introduction. Poly is seen in 10% of endometrial carcinomas in relatively young patients. They have a very high mutational burden. They generally present with a low stage. The problem is that morphologically, they can look extremely high grade, like our case. They can look very ambiguous. Sometimes they can have a mixed like look with prominent tumor infiltrating lymphocytes. They are classified as high risk by current algorithms, but they have an excellent prognosis. So the poly mutation should be a pathogenic mutation, and these are the 11 pathogenic mutations that you can see, and they are usually in exon 9, 11, 13, and 14. Remember, there will be some non-functional poly mutations and non-pathogenic mutations. It is only these 11 mutations that are pathogenic, and only if you have one of these, it should be called a polymutated tumor. So what are the molecular diagnostic tests that are available to do this? Next-gen sequencing, Sanger sequencing, hotspots, snapshot, droplet digital PCR. You do not have an IHC surrogate for this. We use Sanger sequencing in our hospital. This is our paper that we published recently on 327 cases of endometrial carcinoma, out of which 15 showed polymutations, 13 of which were pathogenic. So the ideal situation is that you start with poly testing. If it's pathogenic, it's a polymutated cancer. If it's poly wild, you do the MMR status. If the MMR is deficient, it's an MMR deficient cancer. If it's poly proficient, then you confirm it with a P53. It can be P53 mutated, then it's a P53 mutated cancer. If it is wild, then it's a no specific molecular profile. Can you do this in order? Ideally, you should, but in centers in India, it's not always possible to do this. The reason is sometimes you'll have poor quality slides and blocks, so you may want to do it in the resection specimens. Sometimes you have billing issues. You can't do it on the biopsy. Patient will say, for insurance, I want to pay it and do it in the resection. So that's how it may not be done, but this is the ideal situation which you must follow. Now, the BAGP gives you great guidelines as to when you should do or must do poly testing and when you can not do it. For example, in the group 1 cases and group 3, you can go into the details later. Poly testing is recommended, whereas in group 2 and group 4, you may not, or you can avoid doing them. Group 2 is a low-grade endometrioid stage 1A ER positive, which are anyways low risk. Anyways, you can just follow them up. Poly testing is not recommended. And group 4 is your stage 3, stage 4, which even if you don't do poly, you have to give it chemotherapy. So there is no need for doing poly. It is these two groups that require poly testing, and it should be done. So there is a little bit about multiple classifier. There are tumors, which is around 3 to 5%, which harbor more than one molecular classification. For example, they can be POL-E mutated and P53 abnormal. What will you call it? If the POL-E mutation is pathogenic and it is also showing P53, you have to think that the P53 is a passenger mutation and you have to classify only as POL-E. If you have a MMR deficient tumor, and which is P53 abnormal, remember it is a hypermutated tumor. It can have other mutations. P53 then is considered as a passenger mutation and you will classify it as MMR deficient. If you have a pathogenic POL-E and an MMR deficient, which is maybe subclonal, you have to think that this is an ultra-mutated tumor with some MMR. You will classify it as POL-E. If you have a non-pathogenic POL-E mutation, which is not falling in the 11 ones that I mentioned, but it is MMR deficient, you will call it MMR deficient tumor. Basically, a pathogenic POL-E trumps MMR, trumps P53 in that order. Okay. 7th case, 70-year-old female, postmenopausal bleeding, endometrial biopsy at an outside center, was not subtyped. It was only graded and called high grade because the center did not have IHC. And I think that's a very, very reasonable approach. If you don't have IHC, if you're having difficulty, but at least an attempt should be made to say whether it's endometrioid, non-endometrioid, or maybe if you can't do that, you can at least say it is high grade so that the further steps can be taken. The slides and blocks of the biopsy were submitted for review. Actually, the circles represent, there are 3 colors, 2 blues, 1 red and 1 green. The red is the majority, which showing one morphology. Believe me, the green was showing another morphology, and these 2 areas were showing a different morphology, all under the same slide. And as you can see, this is a single endometrial biopsy. The endometrioid area was there, which showed, the majority showed an endometrioid type of morphology. One area showed a papillary morphology with high-grade nuclei like a serous area. And one area, lo and behold, looked like a clear cell-like area. Now, immunohistochemistry was done. And you can see in the inset, the areas, the endometrioid area was strongly and diffusely positive for ER and PR. The endometrioid area was P53 wild and P16 lack of block. The endometrioid-like area showed intact MSH2 and MSH6, but showed loss of MLH1 and PMS2. Your serous-like area showed block P16 and P53 mutated with intact MMR IHC. The clear cell area showed lack of ER and PR, lack of block positivity for P16, strong diffuse cytoplasmic napsin, and P53 was query wild. This is the serous-like area which was mutated, and this is your clear cell-like area which is showing query wild. MMR was proficient in the clear cell area. And just imagine this is one endometrial biopsy, but it has 3 areas, and 3 areas were immunohistochemically distinct. Endometrioid area was ER and PR strong positive, MMR deficient, MLH1 and PMS2 loss. Serous area was block positive for P16, P53 mutated, MMR proficient. Clear cell area was negative for ER and PR, strong diffuse positive for napsin A and MMR proficient. So what is your impression on this? Is this an endometrioid carcinoma? Is this ambiguous morphology where you cannot identify the different types like the previous case? Is it a true mixed endometrial carcinoma or you're not sure? If I have attendees left, I don't know how many are still online. I think maybe someone can tell me how many are still online. Dr. Pushra, Dr. Noshin, if you're there.
Yes, ma'am. We have 77 participants right now.
Great. So wonderful. I'll wait for maybe 15 people. Right. So the majority, okay, 12, feel that this is a mixed endometrial carcinoma, and very rightly said so, because there are 3 different components. Each of these components morphologically look different, and each of these components, as I said earlier, have distinct immunohistomorphologies. And just to remind you, further testing was done because it was MMR deficient. The majority of it was endometrioid, which was MMR deficient, and an MLH1 promoter hypermethylation was detected. And a poly testing was also done, which was of the wild type. So this was truly a mixed carcinoma of the uterine corpus because it had more than 2 distinct histological types, with one component at least being serous or clear cell. This was not a dedifferentiated carcinoma. This was not a carcinosarcoma. This was not ambiguous because you could clearly classify it. And it's desirable to have an immunohistochemical demonstration of the distinct carcinoma types if you want to call something a mixed carcinoma of the uterine corpus. So how much amount of the high-grade component do you need? Well, the ISGIP recommends that you don't need any minimum amount of serous or clear cell as long as it is recognized confidently. How can you be confident? Of course, you're confident on morphology, but the confidence increases when you apply immunohistochemistry. And each tumor type should be reported with a percentage composition and the grade of each. The overall grade is 3, irrespective of the percentage of serous or clear cell. Now, molecularly, this is a paper which addresses the molecular profile of this. The data suggests that the majority of these tumors begin as a single clone and diverge along 2 pathways: a tumor progression where one component shows additional mutations, or a tumor divergence in which tumor components have both shared mutations and mutations unique to each component. Now, the same paper here shows the results of targeted sequencing in these mixed endometrial carcinomas. There were 8 cases in this paper, where the center column shows gene mutations that were shared between the different components, and the right and left shows the gene mutations which were limited to each of these components. So because we call this a mixed endometrial carcinoma with serous and a clear cell component, which are all high-grade components, this patient underwent a full complete staging surgery, bilateral pelvic, para-aortic, and infracolic omentectomy. And this is the value of good tumor typing, because your surgery will depend on your biopsy, the extent of the surgery. It was a mixed endometrial carcinoma, less than 50% myometrial invasion. And if you did the AJCC staging on, which is an anatomical staging, it is PT1A. My question is, now that you have a FIGO 2023 staging and all this is available to you, that it was P53 mutated component was there in this tumor and poly was wild, how will you stage this as for FIGO 2023? Even if you don't do it in your center, but if you can, tell me, now that all this information is available, how will you stage this tumor? Anatomically, it is 1A because it is invading less than half of the myometrial thickness. but how will you stage this? And this response is sort of, I kind of will wait for a few more people to attempt it. And it is absolutely all right not to know. You can always refer your CAP guidelines or the paper to see what it is. The house is divided right now. I will straight away go to the answer. So this is your FIGO staging. This is a prior FIGO staging or your PT&M staging, which was an anatomical stage, where 1A was less than half, 1B is more than half, stage 2 is cervix, stage 3A is serosa and ovaries, and vice, and etc., etc. So it's an anatomical staging. Then now you have the FIGO staging of endometrial carcinoma in 2023, which also received some criticism that there was too much information too soon. Basically, this FIGO 2023 takes into account all pathological parameters. You need to know for FIGO 2023 aggressive and non-aggressive, and I've told you non-aggressive is only 2 cancers, endometrioid FIGO 1 and FIGO 2. Endometrioid FIGO 3, serous, clear cell, D. diff, undiff, carcinosarcoma, mixed carcinomas, mesonephric, GI type are all aggressive, okay? LVSI is taken into your FIGO, so you have to know what LVSI really is. You can't be doing guesswork for LVSI. Size of lymph node metastasis is taken. Sometimes you can see endometrioid carcinomas involving both the ovary and the endometrium. There are criteria now, and there is a staging for synchronous endometrial and ovarian tumors. And the most important thing is that FIGO 2023 integrates the molecular classification. So if you have a P53 abnormal clone, automatically, irrespective of the myometrial invasion, it becomes a stage 2C. And as I showed you with that earlier block, stage 2C means the patient needs chemotherapy. And that was what the patient received. It received adjuvant chemotherapy and radiotherapy. I promised you that this is the last case. 58-year-old female, postmenopausal bleeding, underwent total abdominal hysterectomy and bilateral salpingo-oophorectomy at an outside center. And we received the case only in March, and slides and blocks were submitted for review. And I wanted to show you this, and I would like you to definitely participate in this poll. This is a low power view, and this is the high power view here, and a still high power view. What is your diagnosis? Is this a high-grade endometrial carcinoma? Is it a low-grade endometrial carcinoma? You don't know, you're not sure. I didn't describe it to you, I just showed you those slides. Should I show you again? Would you like to attempt this? I'll be really happy if you did. Okay. There'll be 2 of you, 4, 5, 6. Whoever's awake, whoever's had dinner, please attempt. Don't know, not sure is going to be very valid. So attempt that also. Don't have to put it. Okay, I stop. So what do you think this is? Anybody would like to speak and tell me? Unmute and tell me also, it's fine. Neil, Sanjana, Chetra, Nangsam, Manya, Anurati, Ishan. Okay. So this was a completely autolyzed endometrium. It wasn't fixed properly, so nothing worked. You can't do tumor typing. So 77 feel it's high grade. No, this is just autolyzed endometrium. No tumor typing, no tumor grading, no IHC worked in this case. No molecular can be done. So what is the problem with this? Terrible, terrible, terrible fixation. So I want to give a shout out to Dr. Rabin, who published this paper, and I was very happy to participate in this, which was an international feasibility of applying diagnostic essential criteria to the 5th World Health Organization classification of FG2 tumors, that there is a global gap in healthcare equity. So where there are centers in India which forget about molecular, we are struggling with good fixation. And then there are criteria in the WHO which says you have to use certain ILC. So I really want to, appreciate this paper where there is an, issue where there is this discrepancy between various parts of the world. And a shout out to Drs. Vikram Deshpande, Dr. Sanjay Pai, and Dr. Benjamin Meza, who have stressed and appealed that there should not be inequality in cancer diagnostics. So, but I do want to stress that morphology is really, really important. But how will you see morphology if you did not fix your tumor or your specimens properly? Also, heartfelt gratitude to the Traveling School of Pathology, which is Dr. Borges's dream, and Dr. Gujral is so passionate about, and I'm so happy to be a part of it. Just for all of you, this is a project under the aegis of the National Cancer Grid, and this involves the establishment of a Traveling School of Oncopathology, which helps train surgeons and pathologists to adopt uniform practices during oncosurgery and gross examination of tumor-bearing resections, respectively. This is actually a mobile school of resource persons, and we all, more and more people should actually be a part of it so that we can go to remote areas and we can teach people, including our technologists can also go here and teach people at least how to fix the specimen so that we don't get sections like this where even tumor typing and grading is not possible. So at the national level, we have put our best foot forward and formed the Gynae Pathology Society of India, which has got a very fancy name called GYPSY, and we conducted our first conference at PGI Chandigarh under the leadership of Dr. Radhika Srinivasan, and with a dazzling array of national and international gynae pathologists who had come for it. And we continue to collaborate with ISGYP and the British Association of Gynae Pathologists. And I would appeal to all of you, there is a lot of resource material and they're all free papers actually, especially the ISGYP Society of Gynae Pathologists, the Endometrial Carcinoma Projects, has numerous papers under its headings, right from grossing to the IHC, to morphology, to molecular, and the BAGP also. These are all free resources which you can access. You will get so many pearls of wisdom from it, and you're going to avoid pitfalls. And I really appeal to all of you to go through these resources. There are huge clinical implications to our correct diagnosis. First is the recognition of the mismatch repair deficient endometrial carcinomas, because if we identify them, we identify SAND syndromes of like Lynch. We identify patients who can get the correct treatment in the form of immune checkpoint inhibitors. There is an advent of HER2 testing in P53 mutated cancers like serous carcinomas and carcinosarcomas, as shown by Dr. Alina, and this is a very important and a very trending topic, and you need to be aware of that. And you've also seen a few POL cases, as I showed you, where if you do it, you are reducing over-treatment in some patients because these carry an excellent prognosis. However, I would like to say that morphology remains crucial in typing and grading. It is required for the correct management to able to distinguish endometrioid from non-endometrioid. There are subtypes of endometrial carcinoma, as I showed you, the mesonephric, the GI type. I showed you all these fancy tumors as well. And there's a growing list of non-endometrioid. You need to be aware of it. Molecular classification is required wherever resources permit. Just wanted to also emphasize that now with the FIGO 2023, the entire uterus actually rests on the shoulders of the pathologist. And as said in Spider-Man, with great power comes great responsibility. So it starts with good fixation. So you fix your specimens well, you're going to get great tissue. You will be able to type the tumors. You'll be able to grade the tumors. Your tumor tissue will be amenable to doing decent IHC. You'll be able to send it for molecular testing. So please remember that. Humble thank you to my colleagues at Tata Medical Center in Kolkata, my fellows, my technologists, and the Department of Molecular Pathology, Cytogenetics, and the Gynae Oncology DMG group, which makes learning so important, and I learn every day from them. So with that, I thank you for a patient hearing, and now I'm happy to take questions. I'm going to... stop sharing.
Ma'am, there's a question.
Yes.
In carcinosarcoma, carcinoma component must be serous or endometrioid can be present.
Like I said, the most common partner in a carcinosarcoma is usually their serous carcinomas, which are P53 mutated. But you can also have non-serous. I've seen endometrioid also. You can see. So the important thing is not to try and split hairs. You see a malignant epithelial component. Remember, it should not be a benign epithelial component. If it's a benign epithelial component and a sarcoma component, it's an adenosarcoma, and that comes under the mesenchymal tumors. It doesn't come under the endometrial neoplasms. But to answer your question, the most common is serous, and but other tumors can also exist.
Another question is that if the endometrioid carcinoma involvement is seen in the cornual section of the uterus, but otherwise the entire fallopian tube does not show tumor, should this still be considered as adnexal involvement, that is stage 3A?
No. Be careful when you call that adnexal involvement. Yeah. And make sure that you are, and she said there's no tumor elsewhere. No. Yeah.
Okay.
Any
There are no
other
further
questions?
questions. No further
That's
questions.
great. That's great.
Thank you so much,
Thank you.
Alina ma'am and Divya ma'am
Thank
for
you,
showing us.
Alina. Thank you, Dr.
Good.
Bushra.